I'm often asked why family caregiving is such a big issue today. Why do advocates call it a looming crisis? Haven't families been caring for loved ones who are ill or disabled ever since time began? The answer is, of course, families have always taken care of their ill or disabled loved ones. Neighbors helped neighbors even if family wasn't around, and even communities helped care for the ill among them. But the nature of caregiving has changed radically. In the past, families didn't provide care for as many years as we do. Families didn't care for loved ones who are as ill, aged, or disabled as ours are. People died quickly from acute infectious diseases. Today, most people die from long-term chronic conditions such as Alzheimer's or heart disease. In the past, families didn't live in a highly mobile society as we do today. Families didn't care for loved ones when so many women were employed and waited till their 30s or even early 40s to have children. Families didn't provide care at a time when health care costs and the questions of who should pay for them was such an issue of concern. Families didn't provide care at a time when medical science had unlocked secrets about how to save and extend lives in ways that were previously unimaginable. And families didn't provide care at a time when the average age of the population was on the rise and the aging baby boomers would soon be entering their senior years. It's for these reasons that caregiving is so very different today than it ever was before, and why we must address the issues that family caregivers and their loved ones are facing and redress the wrongs that make their lives so much more difficult than they need to be. We have an exciting agenda for today's meeting, a mix of presentations, comments, and Q&A. We're honored that Congressman Ed Markey will be joining us, and you'll be hearing from him shortly. When the program has run its course, I will try to sum up what was talked about. And once we've had more time to digest it, NFCA will issue a final report on the meeting that will be posted on our website. Meetings like this, of course, just don't happen. They're a result of hard work by many people and the generosity of others. And so before we get started, I must take a minute and say some very special thank yous. To our gold-level corporate sponsors, Teva Neuroscience and GlaxoSmithKline, we are very, very grateful. Both of these companies have been longtime supporters of NFCA, and helping to make this program possible is one of the best things that they've done. I've already noted that over 40 organizations and businesses are party to this event, and there were 20 very hard-working individuals from these entities that did the actual work of planning today's event. Key committee leaders are Linda Gyad and Kara Macaluso of the National MS Society, Paul Lynette of Care for LLC, Ellen Salamont and Andrea Cohn of Houseworks, and last but certainly not least, John Paul Morosi, NFCA's New England Caregiver Community Action Network representative and president of Bringing Elder Care Home. Before you leave, I must ask you to fill out the yellow evaluation forms that are in the back of your packets. We need your feedback so that we can make future programs better. And you'll also note in your packet there are the names of everybody who has participated in helping to make this program what it is today. Also, there are descriptions of several pieces of state and federal legislation. We urge you to read them and get to know what the possibilities are for bringing about change. And so we are going to get started with the work of this meeting, Preparing to Care, Information to Action. This morning's program is going to be moderated by WGBH Senior Health Desk Editor Madge Kaplan. Madge has been a longtime friend of family caregivers. She's well known to both Boston and national audiences for her signature program, The Marketplace Health Desk. Her show puts a human face on the crossroads between healthcare and medicine, business and medicine. She's the recipient of the Pew Charitable Trust Primary Care Journalism Award and the 2000 and 2001 American Academy of Nursing Media Award. Please welcome Madge Kaplan.
Well, I guess this wouldn't be America if we weren't awaiting a congressman who will be with us, I'm sure, shortly, Congressman Markey. He's here. Aha. All right. Well, he's shaking hands. All right. Well, let me get a few things underway and out of the way as he enters the hall. Like many of you here today, I'm drawn to these issues both personally and professionally, so I'm honored to play your role as moderator. We have tremendous resource people with us here today. We have our sort of speaker panelists, and then we have resource panelists, and we'll be introducing all of them shortly. I also want to welcome everyone who's tuning to this program via the internet, thanks to WHYY and its partners. If you want to watch this whole event again or tell people who have missed it, wgbh.org/forum. In about a week, we'll have this up as an archived on-demand event that you can watch via the web. Okay, well, we are indeed very fortunate to have a very distinguished member of Congress with us to start us off, and that is our very own Congressman Ed Markey. And he's going to speak first, and time permitting, we'll take a few questions for him, and then we'll let him go on. So let me introduce Congressman Markey to you. Okay. I'm going to... Edward J. Markey is the highest-ranking Democrat on the House Subcommittee on Telecommunications and the Internet. He has shaped more than 20 years of telecommunications policy while continuing to champion consumer rights, health reform, the needs of the elderly population, the elimination of large monopolies, the conservation of environmental resources, and the reduction of nuclear threats. Representative Markey is consistently rated as a legislative hero by the Conservation Law Foundation, the Consumer Federation of America, the Children's Defense Fund, and the National Education Association. In 1999, Representative Markey founded the bipartisan Congressional Task Force on Alzheimer's Disease. His leadership is considered a major reason that federal funding for Alzheimer's research has significantly increased. Alzheimer's demonstrations projects have expanded to 25 states. The Alzheimer's Clinical Research and Training Awards program was initiated to encourage and fund the clinical research and study of new treatments and preventions for several promising Alzheimer's researchers. Funding for the Family Caregivers Support Program has increased, and the homebound restriction that prevented Medicare home health beneficiaries with Alzheimer's from attending adult daycare has been lifted. Representative Markey is the author of the David Jane Homebound Reform Act, which was introduced in May 2003, and he continues to make the liberalization of restrictions on Medicare beneficiaries deemed homebound a personal priority. Ed Markey was born in Malden, Massachusetts. He is married to Dr. Susan Blumenthal, and I give you Representative Markey.
Thank you so much. And yeah, but so Alan Solomon, Alan asked me to come over here and to kick off this morning. And my relevant expertise on this subject is that my mother passed away from Alzheimer's 5 years ago. Is it hot in here? It's really hot, isn't it? Do you mind if I take this up? I mean, it's so hot. So that's my, that's kind of where I checked in on this issue. And the, and all of you know how you can become a real expert on this subject. And right now, 4 million Americans have Alzheimer's. And by the time all the baby boomers have retired, 14 million Americans are going to have Alzheimer's. And as you all know, if one spouse has Alzheimer's, the other spouse has Alzheimer's as well, or some other family member has it with them. So that means that 28 million Americans at a minimum will have that disease to deal with when, by the time all of the baby boomers have retired. So that's a pretty serious problem if you add in the 1 million people today who have Parkinson's and extrapolate that out by the time all the baby boomers have retired, plus the ALS, and go down that whole litany of diseases that requires some type of caregiver on an ongoing basis to be helping with that individual. So as any of you know who has had somebody with Alzheimer's in their family, it's a very difficult thing to deal with. And it was for me, and it was for my family. Because my mother was valedictorian of her high school class and president of the senior class. But under the old rules of women in America, when her mother died, that is when my grandmother died in 1925, she died more than 20 years before I was even born, one of the girls had to just stay home. Right? That was the social safety net before Franklin Delano Roosevelt. Somebody had to stay home. So my mother had to stay home and raise the 3 younger sisters in the family, which she did. And she did an excellent job with that family. But that was the social safety net. And so she didn't get to go to college, and she didn't get to do all the things that a valedictorian should do. And so we still live approximately 8 doors down in Malden from where my grandfather got off the boat from Ireland. That's just the whole fate of a family is determined by events that can rise up because of disease. So when she started to show these symptoms, we were unable really to deal with the fact that her brain could be deteriorating, because she used to do my calculus in college for fun, even though she had never had calculus, if you know what I mean. Okay, so that was her brain, though. It was just amazing, and all of the women, all of her sisters, all had this incredible mathematical brain, so that all of their children all went to MIT and majored in math, etc. So in our family, however, by the time my mother was ready to get married, the only person who was still around was the milkman, my father. And so she married my father when she was 38. My father was 34. You know, she was a mother, essentially. And now she was looking around. So she married a milkman. And so, unfortunately, as my brothers and I always say, the mathematical skills for my brothers and I kind of got watered down a little bit, okay? But as we grew up, you know, we always felt, as did my father, that we had the smartest mother going. And then her brain started to get a little bit funny in about 83, 84, 1985, right? But we all just were in denial, 86, 87. And finally, maybe about, 89 or so, we went over to Harvard and over to Mass General and had her diagnosed, although my father was still not willing to accept it. And a very nice doctor, Dr. Groden at Mass General, said, well, Mrs. Markey, why don't you count backwards from 100? And when she reached like 93, she couldn't count backwards anymore, which is kind of funny for a mathematical genius. So I was in denial, so I said, Ma, on me Gallia et divise in tres partes. And she says, all Gaul is divided in 3 parts, And so then I threw some French at her, and then she translated the French, and the doctor took me and my brothers and my father outside, and he said she can remember everything from when she's 16. She just can't, her long-term memory is still pretty much okay, but it's her short-term memory is now gone, and it's just going to continue to get worse and worse, which is kind of discouraging. So then as the years went by, probably like 92, 93, we said to my father, why don't we talk about putting Ma in a nursing home? And my father said, Eddie, he said, it was an honor that your mother married me. Your mother is never stepping foot in a nursing home. Don't ever raise it again. I'm going to take care of her. So when my father was 80 and 81 and 82 and 83 and 84 and 85 and 86 and 87 and 88, he took care of my mother every day, all day long, 24 hours a day, the middle of the night, when she would soil the bed, roll her over, get her out of bed, change the clothes, pick her up again, put her back in the bed, night after night, day after day. Now, the thing about my father was that he was a milkman. He was a very, very strong man. And his arms were the size of my legs. My brothers and I used to say, we got a really bad deal. We got my father's brains and my mother's strength. You know, if it had worked out well, we would have been, you know, Rhodes Scholars, you know, I mean, Renaissance men. But it just didn't quite work out that way. But as the years went by, he just got smarter and smarter and smarter, you know, as we learned from him, you know, because he was a wise man, it turns out. Huh? But no one was ever going to touch my mother from midnight to 8 a.m. in a nursing home. That's what he used to say. No one. Who the hell are those people working, he would say. You know, what are the standards? What are the protections? No one is going to slap your mother because she's screaming out in the middle of the night. Okay. Well, that's a commitment, huh? An incredible commitment. So he did it. He made it all the way to 1998. She passed away. She never stepped foot in a nursing home. She passed away at age 90. He did it. An amazing commitment. Now, we used to have somebody come in for an hour a day, some home care, health care worker, right? Come in to help him out. And that was a big break for him. Big, big break to have somebody give him just a little bit of a break. You know, clean her off, you know, do her hair, talk to him, keep him going. But it was always hard for me to deal with kind of the policy implications of it. Because I didn't really want to talk about it because it's hard even today, as you all know, to talk about it even today. Because it's something that's almost more insidious than anything you can imagine, just watching this brain deteriorate. So only after she passed away did I have the ability then to create the Alzheimer's Caucus, which I now have 165 members of Congress I've joined, including Hillary Clinton last month. And what I did was I made it my goal then to try to create a group of people who would advocate for Alzheimer's research and for home health care, nursing home care, Medicare, that would reflect the seriousness of that disease and all of the other diseases that were growing as our society benefited from the investment which was made in public health from 1900 until today. So when my mother was born, 1906, the average life expectancy in the United States was 48 years of age. That is, we had gone all the way from the Garden of Eden to 1906, and we had only made it up to 48 years of age as an average. And if you look at the cemeteries of Malden and Medford and Melrose or whatever hometown you come from, and you just walk through, you'll just be shocked at the frequency with which you get this very early death. But because of public health initiatives in the 20th century, clean air, clean water, safe food, the FDA, Medicare, Medicaid, et cetera, we have lengthened the life expectancy, where it is now out to 78 years of age. So we've added 30 years of life to the average person in just the past century. Quite an achievement for those Americans who invested in those kinds of public health initiatives. Quite an achievement. But with those bonus years, we now see that there are other diseases which show up the older and older the people get that we haven't solved yet. Alzheimer's, Parkinson's, other diseases that all of you are familiar with now tend to show up at a frequency that no longer makes it possible for people to say, oh, you know, that's grandpa, he's just a little touched, or, you know, or just a little senile. Now we see it's a whole pervasive disease across our whole society, right? So that's a challenge then for this generation. How do we handle this issue? What are we going to do in order to ensure that there is put in place a set of programs that will guarantee that we cure it, or we deal with the consequences of not having cured it? That's our challenge. The past generations met theirs. Now we have to meet ours. So in the past several years, we've been able to increase the Alzheimer's research budget. I was able to change the regulation which said that if the caregiver at home was took the patient out of the home to take them to mass, or take them to synagogue, take them to church, take them to an adult daycare center, then they lost the entire benefit. That is, that no one could come in for an hour a day to help if then later on in the day you took that person out, strapped them into the front seat of the car, drove them to church, synagogue, an adult daycare center. So I got that changed in 2000, in the 2000 budget, so that you can do that now, all right? But you also have the problem of, what if all you want to do is just take them down to Revere Beach and sit there looking out at the beach, and you can read the paper, and then the patient can just sit there as well? Can you do that? No, you can't do that. That's illegal. Right? What if you just want to walk them around the Stop and Shop with you? You know, to get them a little bit of exercise. Can you do that? No, that's illegal. Because they are not homebound. You must be homebound in order to receive any benefit. Now, I contend that there is no massive group of people who are all willing to get a CAT scan and try to defraud the government in order to have somebody come in and to wash their behind once a day. Huh? I just don't think there is a whole bunch of people out there. In fact, I think it's just the opposite. I think it's hard to get people to even admit it. I think that's the hardest problem for families, right? To accept that reality. It's just the opposite. So I have, in this year's budget, after extensive negotiation, a pilot project which we're going to have, because I'm going to have to prove it to them that there is no group of people out there, because they believe that it's going to increase by $10 billion the total cost for home health care, because of all the additional people who are going to now want home health care because they can walk around and Stop and Shop or sit down by the beach, okay? But the test, of course, is, will the doctor certify that you've got it? And I just don't think that, one, you're going to find a whole bunch of people who will want to be certified that they have Alzheimer's or Parkinson's, and two, that you're going to find a whole bunch of doctors who are going to be willing to risk their careers saying that this whole group of people has it. So that pilot project will be built into this year's budget. Now, we were trying to double the research budget to cure Alzheimer's. But this year, President Bush only wants to increase the NIH research budget by 2%. 2%. Not double it. A 2% increase, which is just about what inflation is in the United States this year, right? So that's not good news if not only Alzheimer's, but a whole range of diseases which we hope will be will have their clues found which allow for us to conquer them. Now, in 2001, when President Bush took over, we had a huge surplus. We had a surplus which was estimated to be upwards of $5.6 trillion over the next 10 years. the first thought that President Bush had was, how big can I make the tax cut for the wealthiest 2% in the United States? How can I drain all of these revenues? Because that surplus really doesn't belong to the government, it belongs to people out in America. And I'm going to get it back to them, although I'm going to give most of it to the wealthiest 2%. Well, you see, the way I view the surplus was that the surplus belonged to my mother and father. The surplus belonged to the people who created the surplus. Now, under this Republican logic, the people who are the CEOs of companies created the wealth in America, and as a result, they deserve to get these huge tax breaks. But you see, I don't see it that way. Because if your father's a milkman, and you see him leave the house, although you don't see him because you're not even awake yet, if he leaves the house every morning at 5:30 a.m. to start lugging milk up and down stairs, 6 milk bottles per bottle, they're the people who built the wealth of America. The people in the 30s and 40s and 50s and 60s who worked, 10 to 12 hours a day, working really hard. It's their surplus. It's not the surplus. The CEOs are the beneficiaries of the hard work of all these people. But they didn't create it. It was created by 200 million Americans working very hard. And so a surplus, in my mind, is what's left over after you've met the obligations that you have to the people who created the surplus. So for them, you have an obligation to determine what are the health care needs for all of those people before and after they retire. Let's answer that question. If you know that a tsunami of baby boomers are about to join all of the other generations that have already retired, what is going to be the amount of money that you're going to leave over? And they said, well, we'll worry about that then. But right now, our job is to get this tax cut as big as we can right now. So, and it's quite brilliant, by the way. 3 years later, they've destroyed the surplus. There's no surplus left, and we're at least $3 to $4 trillion in the hole. Not $5 trillion to the good, but $3 or $4 trillion down, looking out the next 10 years, 15 years. And so as a result, unfortunately, although they'd like to help, we really can't increase the NIH budget anymore to try to cure it. And there won't be the money there for Medicare, for Medicaid, for home health care in the years to come. Senator Daniel Patrick Moynihan used to talk about benign neglect of programs. That is, don't do any harm. You don't have to help them, but just don't hurt them. Benign neglect. What the Bush administration policy is one of designed neglect. How can we deliberately drain all of the revenues that would be necessary in order to take care of the long-term health care needs of the American public? Design neglect. It's a plan. They don't believe in the government. So I know personally how much my mother was affected by the fact that her mother died when she was 16. I mean, it was traumatic for her and all of her sisters. Always was. Just changed the whole course of the way in which their lives were conducted. So there are no more important events in people's lives than these healthcare events. Huh? They just alter everything. And I think that we are going to have, at some point, a caregivers march on Washington. We have to put a human face on this entire issue. But you all know that the paradox of this issue is that the Alzheimer's patients can't march. First of all, it would be illegal to leave the home or else they'd lose. Can you imagine? Can you imagine how quick they'd all lose their home health care benefit if they were marching on Washington saying the benefit isn't adequate? They'd be gone in a second. But by definition, this is a whole group of people who can't speak for themselves. It's the only disease that's really like it, huh? Every other disease can have people up. You can have a breast cancer or AIDS or whatever much. But here, it's just the opposite. The more that people need help is the less they're actually able to speak for themselves, although the numbers keep piling up into the millions. And the caregivers are tied to them back home. Huh? So it's kind of a silent disease, too. Huh? And it's one that people really don't like to come out and talk about, either. My father was always like that. He didn't want anybody to, because my mother was such a proud person, talking about it would have violated the code which he had built into his brain not to, not to betray this, perfect person that she wanted to be. So it's a tricky one for us, huh? But at the end, I think it's our greatest moral challenge. Because there are some people who believe that having served our country, that they just have to kind of move out of the way, out of our own personal lives and out of the consciousness of the country. But think of how great those people were 100 years ago. Just think about the incredible investment which they made in red brick schools every 8 blocks, when only 7.5% of all people were even high school graduates in 1900. And these generations said, let's build a beautiful red brick school that we have a hard time even keeping open or preserving from a wrecking ball. Or if we do build new buildings, why can't we make them as beautiful as they made the schools 100 years ago, when all of the people were just immigrants from other countries paying the taxes and trying to figure out how to educate, huh? And then they all built a nice hospital up on top of the hill, huh? Beautiful hospital 100 years ago. And they said, we're going to improve the education and we're going to improve the health care of every family. And what a great job they did, huh? And now our country is about 10 times wealthier than they were then. And what do we say now? Oh, we don't know if we can afford to build schools, to give reading programs to every child, or to have a health care program that deals with the modern health care problems, huh? The new issues which have arrived. So that's the challenge. And you are the Army, huh? With me. I'm a foot soldier in this battle. And we can't lose it, because the pain, the suffering of so many families is going to be so great that we can't lose it. We can't lose this fight. We owe it to those millions, tens of millions of families who are going to have these events over the next 10 and 15 and 20 and 25 years. We have to. I believe that this tax cut, this series of tax cuts, are immoral. They're immoral because they deny that there is an issue that you caregivers live with every day. They are in denial. Half of all the people who are now in nursing homes have Alzheimer's. 2/3 are on Medicaid. Those numbers are just going to grow and grow and grow. We have to make sure that the nursing homes have the level of care which meets the test that my father would apply to it in terms of what he would want my mother or your family member to have. We have to have health care. We have to have home health care workers who meet that test too. That if my father wanted to leave the house for an hour and take a break, that he could feel comfortable. We have to have standards that we feel can be met, because we owe it to all of the people who helped to make this a great country. And so this tax cut, this challenge to our society is, in my opinion, the greatest challenge, because it's kind of a silent challenge that every family has to meet, but no family can meet it alone. And if my mother couldn't meet it, the valedictorian, if her mother died, okay, then nobody can really meet it, No one can. And unfortunately, most people aren't like my father. Demographically, it's not the man who stays alive and he's strong and he's taking care of the woman, it's just the opposite. The guy kicks off, right? And it's the woman who is now responsible for taking care of it. Well, he's going to need more help sooner, and the woman's going to be the caregiver, huh? That's the way it works. So how do you deal with that? Well, they need help. Other people are going to have to come into the home, or the nursing home is going to have to be something which meets the dignity of the individual. Huh? Or else there's going to be an awful lot of people who just won't want to deal with the reality of what's going on to their most loved ones. So that's my message to you. And I thank you for everything which you do, because to my father, the caregivers used to be the most important people. They were to me. And when at my father's funeral 2 years ago, all these caregivers came who just used to enjoy sitting in the living room talking to him when they were taking care of my mother. Huh? They became his friends. And that's what happens as well, because as people get older and older, they don't have their own friends to help them anymore. They don't have their own family members to help them, right? So these caregivers become family members in a way, huh? Anyway, as you all know, I get choked, you get choked up too when you talk about these issues, so I am right now. So I'm just going to end it right there. Thank you all very much for everything you do. Thank you.
To lead off with a few questions, and believe me, you'll have time for questions throughout the day. So where is Sona? Okay, go ahead. One step to the microphone here, please.
Good morning. I thank you for the opportunity to be here and to be heard, very much so. I'll be brief, even though I know I represent a lot of other people here today, and I could go on and on about long-term care, but I won't. Caregiving isn't new to me. I'm a nurse, and I raised with my husband a wonderful, challenging, 37-year-old, mentally retarded, developmentally disabled son. He constantly needs advocacy and support. We also had a mother with leukemia, and we took care of her for 2 years. Now, about 3 or 4 years ago, our family responsibilities, caregiving responsibilities, really intensified. My 59-year-old sister-in-law suffered a devastating stroke, and my 91-year-old dad is now frail and suffers from CHF, congestive heart failure. And our small family honors him and his wishes to use whatever remaining resources he has to remain in his own familiar home rather than a nursing home. He can't be left alone right now. He requires care with every single ADL. My husband stayed with him so that I could be here today. Now, our family has been and is faced with overwhelming caregiver responsibilities. Daily challenges. As you said, I can take my father out for a ride, but he cannot get someone to come in and do a home draw to take a 5-second finger prick for his PT-INR. It took 20 hours for me to get one medication for him. One medication. In January of 2001, I found I couldn't balance anymore, so I had no choice but to leave my position as director of Worcester Senior Center. I have not been able to work since. Plus, like so many caregivers, my health has suffered. I am now on disability myself. I am a caregiver by chance and by choice. I'm basically living with Dad now, and relief is very, very valuable. There are many times when I feel I've just about reached the end of my breaking point. We need a better system of respite care so caregivers like me can recharge our batteries and continue onward. How can the Lifespan Respite Bill sponsored by Senator Kerry and Senator Kennedy help someone like me, Senator Markey? And thank you so much for all of your efforts and the opportunity to say what I need to say.
Thank you. Well, first of all, I'm not a senator, but that's not an insult, okay? I don't, that's all right. No, I don't take it that way, okay? Well, again, it's all part of this, it's all part of this battle that we're having, okay? You people are heroes, but heroes need help. You can't do this alone. You can't take care of these people 24 hours a day, 365 days a year without some help. And so it all comes down to a resources issue. It all comes down to how many billions of dollars, how many tens of billions of dollars, how many hundreds of billions of dollars are we willing as a nation to spend to ensure that you get a little bit of help, so that you just don't get exhausted, that you don't get sick, that you don't get worn down psychologically or physically. So that's our real challenge, and it all comes down to the tax cut. I hate to say it, it does. How much? The first thing we should have decided is how much do we need to meet our obligations. Then what's left over is a tax cut. Then we'll fight over who gets the tax cut. Instead, what they decided was how big the tax cut was going to be, and then what's left over is what's going to be there for health care and education. And we have a real problem. And so the answer to your question is it would help you a lot, that bill, but President Bush would veto it if it passed the House and the Senate, and that's the sad fact of the matter. Yes, come on back over to the microphone.
I want to tell you, the inability to focus and concentrate, like just happened to me, is not unusual for caregivers. The simple glue sometimes becomes unraveled.
No,
So again, my apologies.
No, absolutely not. No, oh, no. I'm sure it was a subconscious desire on your part to give me a promotion. Okay, I'm sure it was your brain working at a pluperfect form of activity rather than a substandard. Yes. Anybody else?
Well, I think we're going to move on.
Oh, okay, fine.
Okay, and thank everyone. I think you got us off to a wonderful start, and thank you very much.
No, we have one question over here.
Quick, come to the mic. We're really trying to stay on schedule.
Okay,
so
just sit
please.
down. No. You can.
I
my
defer
name-
to the congressman.
Yes, Congressman. My name's Carlos French. I've been taking care of my
Your
dad.
name is what?
Carlos French.
Carlos French.
My parents lived in South Carolina until back in April. My dad suffered a stroke. My mom suffers from bipolar manic depression. We had to put her in the hospital, bring my dad up. My dad suffered a second stroke in July. He ended up moving in with me. The reason I'm here today is he was just admitted back to MGH for some observation. But the idea that I came up with and I just wanted to share with everyone, for myself, I haven't worked since April. Thank God that my parents have enough to kind of keep us going here in the short term. But one of the things for respite care that I found living in a city as Boston, we have so many universities here within the city with so many healthcare programs. My dad, luckily enough, has had long-term care insurance. Unfortunately, I cannot be paid for doing any type of services with a lot of those programs. I am gay, so my partner, not being married, not being a blood relative, can be paid for these services. So we found a way around that. But the point comes down to it. I also have a lot of other friends that are at university right now. And to bring in health care that would fit, that I didn't have to pay $20 and $25 an hour with, I was able to hire students in the nursing programs to come in and sit with my father for about $12 an hour, which allows me to pay my partner and then in turn pay these folks $12 an hour by stretching that benefit. So it helps us sort of in the long term. So I don't know if you've had any sort of idea to use those type of resources in some sort of internship program with the universities here to give respite care for for home care health providers.
Yeah, we need a march, huh? Don't we? You know, it's like queer eye for the straight guy. You know what I mean? You looked at these regulations and you said, hey, how can we twist it? How can we twist these straight regulations and the bureaucracy and make them work, you know, for your family, which is absolutely, you know, brilliant. And so this incredible group of people who are sitting out here are just as courageous, and you included, as anybody that we have in the Army, anybody that we have who is protecting us in North Korea or Germany or any other place, okay? Because you're on duty 24 hours a day, and you do the work that nobody else wants to do. And it's just incredible how, you know, dedicated and impressive you are. I mean, just impressive people. And in a way, and we came to think of my father as a great man, a truly great man who awed us, my brothers and I, who, my mother raised us not to be milkmen, huh? So I'm a congressman and my brothers are lawyers and all of that. But it turned out that she was no dope in who she married either, huh? And so what each of you do is incredibly important. And what you're trying to do is something that I'll try to help you with. Back here we have my staff. I just want to introduce them to you so that if any of you want to, you can call my office, and I brought them all here with me today. Joe Dalton, can you raise your hand, Joe? Jackie Lavender, right here. These are the people who work on these issues, and Mark Gallagher, right there. If you can raise your hand too, Mark. So if you want to call my office, it's 781-396-2900. We have at least half of my staff who are working on these issues and related issues all the time. So not only your individual issue, but anybody who's here who hasn't been given a chance to stand up today, if you call my office and you tell us what your idea is, then I will then try to make your idea come to life as a policy, okay? Thank you all so much.
Thank you very much. Thank you again, Congressman Markey. All right, we're going to move along, and we're going to try very, very hard to stay on schedule, which I'm sure everyone will appreciate. And I wanted to explain how things are going to go from now on. Our program does go until noon today, and each of our panel members, right to my left, will speak for about 10 minutes. If all goes according to plan, we'll have about a half an hour at the end. We hope for some questions from you, our audience participants and our online participants. If you were given yellow cards at your seats, those are to help you frame some questions if you have it during the course of the discussion, and you can ask that later on. I also want to point out our resource panelists on my far left there. They are here not as formal speakers, but here to also help us with information and answer our questions. They are Jean Brown from Aging Services Program, Region 2 Office, U.S. Administration on Aging. Welcome, Jean. Alita Payne is there, the Director of Child and Family Services for the New Hampshire Department of Health and Human Services. That must be Lawrence Tumino, Assistant Commissioner for Field Operations, the Massachusetts Department of Mental Retardation, and Cheryl Bushnell, Director, Division of Special Health Needs, Massachusetts Department of Public Health. So please take full advantage of those folks as well. There's also a resource table in the back. All sponsoring agencies were asked to bring materials. Please take advantage of those materials. Make sure to stop by and speak to the folks back there as well. As some of you are clearly already doing, feel free to get up at any time that you need to for coffee, some nourishment, and the restrooms. Also, if you weren't aware of this, there is free access to the museum today for anyone who would like to stay on, and your name tag apparently serves as your ticket to get in. Okay, turning to our panel right here. That includes Heather Mazur, Joanne Prince, Sue Miller, Susan Leahy, and Alan Solomon. And what I'm going to do is basically Before each person speaks, I'll tell you about them in the order that they will be talking. Heather Mazur is the Director of Domestic Policy for Senator John Kerry. There's the Senator. And Mazur advises the Senator on legislative strategy for all health and social policy issues. She joined his staff in April 2003 after 5 years as Director of State Affairs for the National Association of Community Health Centers. There she worked with federal and state legislators to enact laws, policies, and regulations to promote health centers for the low-income and uninsured patients that they serve across the country. Heather spent her time at the association becoming an expert on Medicaid and the state child health insurance program, sometimes referred to as SCHIP. I give you Heather Mazur.
Good morning, and thanks for having me be here with you today. There is a gentleman who, upon his death, was surprised to find out that they had a new admittance policy in heaven and hell, and they were actually giving choices. You could decide what you wanted after testing each out. So, first opportunity was to go down to hell, and when the doors of the elevator opened, people were golfing, having nice meals at restaurants, laying on sunny beaches, relaxing, having a wonderful time. After his day in hell, Frank went up to heaven, spent the day communicating, with family members and friends, lost loved ones, relaxing, being one with his Creator, very much at peace with himself. And when the time came to choose, he actually said to God, "I'm sorry, God, I really, really liked heaven. Believe me, I do. I really thought it was a great place. But I'm an avid golfer. I love fine food and wine. The beaches were amazing. I'm gonna take my choice and spend my time down in hell. But I appreciate the opportunity to have the choice." The Lord says, okay, sends Frank back down to hell. The elevator doors open up, and all of a sudden, everyone is picking up garbage and trash, complaining about an aching back and sore muscles and pains. No nice restaurants, no golf courses. And Frank says to the devil, "What's going on here? I was here the other day and it was a whole different environment." And the devil said, "Oh, Frank, yesterday we were recruiting you. Today you're staff." And that story came to mind because I don't know any family caregiver who was actually recruited for the job. It's something that we do out of our passion for our family members, to honor them, to love them, to respect them. And the wonderful thing about having a conference like this today is we're all gathered here today to be able to acknowledge that that job is not always a picnic. There are a lot of stresses involved with being a family caregiver. Emotional stress, financial stress, physical stress. And there's things that policymakers need to do to be able to help you with this job. So I'm going to go over today a few of the policy areas that I think can be most helpful in agitating and advocating for changes in our government at both the state and federal level to help support family caregivers in the all-important mission that you do. There are 4 basic public strategies so far that have been used to support caregiving. It wasn't until the year 2000 that the Older Americans Act was amended to add an acknowledgement for family caregiver needs with the National Family Caregivers Support Program, which provides some direct services funding to the states to be able to support information, resources for folks who want to know what can we do to have help with family caregiving, and to help provide a little bit of relief through respite care. Much more needs to be done. Of course, family leave policies have been instituted for both at the federal level and some paid family leave policies at the state. Some have proposed using tax incentives as a way to help offset the cost that family caregivers incur in this role. And there are also other forms of financial compensation through vouchers or various Medicaid waiver programs that are focused on supporting home and community-based choices rather than the institutional bias that exists in our programs. And I'll talk about how all 4 of these components are combined in 5 major pieces of legislation pending before the United States Congress. Your question to Congresswoman Markey had to do with the Lifespan Respite Care Act, and I'm going to guess that many of you here are familiar with the fact that this legislation, sponsored in the Senate by Hillary Rodham Clinton of New York and co-sponsored by Senators Kennedy and Kerry and a host of others, supports creating additional lifespan respite care programs that are coordinated systems of accessible, community-based respite care for family caregivers and children, as well as adults with special needs. And in Washington speak, of course, respite care means you need a break. What can we do so that family caregivers are given a break and able to do something other than the 24-hour care that is required of you so often? This bill hopes to provide you resources through the development of these programs at both the state and federal level, as well as training and recruitment of respite care workers and volunteers so that those who are coming in to help give you that respite care are trained and skilled in providing a care in a comprehensive way. Adults with special needs are defined broadly as a person 18 years of age or older who require care or supervision to meet the person's basic needs or to prevent physical self-injury. The funds provided in this bill would give grants to states, certain eligible nonprofit entities, or a consortium of groups of providers and folks who need care within different blocks of a state. The second bill that I'm going to discuss is an expansion of the Family and Medical Leave Act, often referred to in Washington as FMLA. And of course, in 1993, this was the first piece of legislation that President Clinton signed into law. It allows workers up to 12 weeks of unpaid leave to care for newborns, seriously ill family members, or to recover from one's own serious illness. And employees receive assurances that they will be able to hold on to their health care and be able to return to their same position if they exercise their right to take the leave under this act. As of the year 2000, more than 35 million employees have taken leave under FMLA. 31% took leave to take care of a seriously ill parent, child, or spouse, and 42% of those taking leave are men. Congress passed this bill in part to combat the lingering effects of laws that discriminated on the basis of gender. FMLA is helping to level the playing field and eliminate stereotypes that say only women can be caregivers and only men can be breadwinners. And while FMLA represents one of the most significant advances for families and family caregiving in the country, more must be done to strengthen the laws. There are limitations of the law as it currently exists. It only covers workers in companies that have 50 or more employees. So all the folks who work at small businesses across the country don't even have the option to use Family and Medical Leave Act. 43% of the nation's workforce is not covered because of working in these small businesses. 3.5 million people have needed leave but did not take it, 78% because they couldn't afford to. There are only 48% of working parents that have paid sick leave in this country, and 76% of low-income workers have no paid sick leave at all. Senator Tom Daschle, the Democratic leader, has introduced a bill called the Right Start Act of 2003, Senate Bill 18. And I have a copy of most all of the slides and the statistics that I'm talking about are in your packet for those of you furiously note-taking. The FMLA expansion covers work sites with people taking it from the 50-person threshold down to 25, so that any small business employer who has at least 25 employees would be required to allow for this leave and coverage as well. It would provide $400 million as well to give resources to the states to help partially replace some of the income needed for individuals on leave. And at the national level, there's currently no other legislation that addresses the expansion other than this bill. However, the National Partnership for Women and Families is now launching a nationwide campaign for family leave benefits to promote a variety of public and private models for paid leave. In 2002, California became the first state in the nation to adopt a comprehensive family leave paid law at the state level. And there are many bills pending in 27 states across the country, including Massachusetts and Maine. Many of these bills, as most of you know, the states are a wonderful incubator of ideas. Most of our best things that are done in Washington are ideas that we've copied from successful programs that have been started in the states. And I think these bills represent a wonderful model, not only to provide state relief at the local level, but to use where these programs work and where the best ideas are being promoted as a framework for something that shouldn't just be done in Massachusetts or in Maine or any of the other 27 states, but what should become the federal law of the land. One bill pending in Massachusetts that I find particularly interesting to consider promoting at the federal level is the legislation which says if you're leaving a job as a full-time worker and going down to part-time or even becoming unemployed because of family care needs, you should be able to qualify for unemployment insurance during that period of time. I think that's an excellent idea worth promoting, and we're looking at a lot of state proposals across the board as we're formulating our own long-term care proposals in the Senate. One other thing worth noting on the Family Medical Leave Expansion Act, besides the expansion to the number of people who would actually qualify to take that leave, it expands the number of purposes that the leave can be used for as well, giving 24 hours of leave for children's academic school activities or for literacy training for the employee, and also for victims of domestic violence who need to leave their jobs for issues related to that experience. Another piece of legislation which really strikes to the heart of family caregiving is a bill sponsored by Senator Mikulski of Maryland, and Senator Kerry is also a lead co-sponsor of this bill. It's called the Family Caregiver Relief Act of 2003. And this bill would change what's known right now as the Child Care Tax Credit and turn it into a Family Care Tax Credit, and say $5,000 are going to be available as a refundable tax credit to family caregivers who have to expend their own personal resources on home health, respite and adult daycare, durable medical equipment like canes and wheelchairs and other sources of equipment needs, various therapies, and even prescription drugs. Nearly 30% of all caregivers in this country make less than $20,000 a year, and more than half make less than $35,000 a year. And yet, most caregivers spend on average 11% of their own personal income, those limited dollars. 11% of $20,000 is a big chunk of money for someone earning in that category. 11% of $35,000 is a big chunk of dollars for someone who's already struggling to make ends meet and struggling to care for someone that they love. Let's put some money on the table. If we can give tax breaks to the rich, we can give tax breaks to family caregivers who need to be able to recoup some of the money that they're spending out of pocket. This legislation is, of course, a step in the right direction. We'd like to see more focus on not just giving family caregivers money back that they expend out of their pockets, but let's look at ways to reform and change our federal laws so that the time that is spent as a family caregiver is something that is rewarded as work under these programs as well. That gets me to legislation that's known as MICASA. MICASA is a bill that is an acronym for the Medicaid Community-Based Attendance Services and Supports Act. And quite cleverly, MICASA, while that's the acronym, is also Spanish for the word my house. All of us who watched Wizard of Oz over the years knows that one of the most famous lines in that movie is, "There's no place like home. There's no place like home." And yet in our current Medicaid program, the institutional bias that exists in forcing people to be in an institution in order to qualify for the care and services that they need is pervasive. And this bill tries to correct that. This bill tries to give resources to the states and communities to implement what is already a requirement handed down from the Supreme Court and what is known as the Olmstead decision. This decision said we must get to the point of providing options to people where they can age in place or get the care and services that they need, whether they're elderly or otherwise. If you need assistances with activities of daily living, you should not have to be institutionalized. to qualify for the Medicaid services to pay for that care. If you otherwise qualify in every way except for the fact that you want to stay in your own home, we need to change these programmatic rules to get to the point where those resources follow the people. You may have heard it's often called the New Freedom Initiative or the Money Follows the Person's Initiative. Let the money follow the person. And where this is important is not just for your family, the person in your family for whom you may be taking care of. It's also important for you as the family caregiver, because the way these programs are working right now is through a Medicaid waiver initiative called Home and Community-Based Waivers. And without getting too technical about the way the Medicaid program works, but there are all kinds of laws on the books that says this is how Medicaid works, this is how it functions, these are the requirements to be able to qualify for reimbursements or to be eligible for the program to begin with. But there's also a provision on the books that says we'll give states a waiver of all of these rules and requirements under certain circumstances and have them give them flexibility to design their own demonstration programs. Within that flexibility, many states are creating slots for home and community-based services where the money does indeed follow the people. Now, we'd like to see not just these home and community-based waivers expanded, because there are many, many places where this program is on the books, where the states have much more demand for the services than the slots available to serve it. Where MICASA strikes at the heart of, let's forget about this wavering business. Let's forget about trying to cobble together piece by piece and state by state programs to be able to provide home and community-based services. Let it be the law of the land, part of the way the Medicaid program works on its own. Let's end the institutional bias. Congressman Kerry is also a proud co-sponsor, original sponsor of this bill with Senator Harkin from Iowa. And we participated just this week in a national rally on Capitol Hill to try to get this bill passed in the Congress. The final piece of legislation that I'm going to discuss is the prescription drug bill that's currently pending in Congress. This legislation deals not only with how to add a prescription drug benefit to the Medicare program for seniors, but also some reforms of the Medicare program in the way that care is provided. While the prescription drug benefit itself is, I'm not going to go into all the details of, we could have a whole conference on what is in this prescription drug bill. There are 1,000 pages in the Senate and 700 pages in the House, and they're in a conference committee right now trying to iron out the differences. But separate and apart from whether or not we're going to get a prescription drug benefit for seniors, some of the reforms that I think are important for you to know about are related to home health care. There are proposed in the House side cuts in the service benefit, as well as increasing beneficiary co-pays that we are joining many of the home health advocates and several others in the Congress to fight strongly against. They're wanting to add a $40 to $50 copay per episode for home health usage in the House. One of the things we're trying to remind people is that if anyone knows anything about the program and the benefit, there was a copay that existed from 1965 to 1972, and it didn't work. It didn't work because that level of copay is something that discourages people and families from being able to use the benefit. And instead of allowing to take care of them in a more appropriate and cheaper setting in the home, they are then, of course, institutionalized. The thing that never makes sense with the bean counters in Washington is there's this bias towards institutionalization, and yet it's the most expensive form of care. And so what we are trying to get at is to sort of beat this in the head of those who would otherwise say, well, our biggest obstacle, quite frankly, and I'm glad this is a New England conference because I'm going to say something negative about a member of Congress from California. Bill Thomas, the House chairman of the Ways and Means Committee, has been on this vendetta against the home health industry for a number of years, and he has it in his mind that we've got to increase this copay because we got to modernize the program. Every other benefit pays a copay in order to receive services. Well, what we need to remind him is it's not modernizing it to add a benefit. That's going back to 1965, and we already know that it didn't work. Chronic care is another issue that is addressed in this bill. One of the things that we are trying to get the message across in Washington is that 20% of the beneficiaries of Medicare consume 80% of the expenditures. Those with chronic diseases take most of the resources out of the program, and yet we're doing a miserable job of coordinating care for these folks. There are a couple of demonstration projects on care coordination and management, as well as adult daycare services. We're hopeful that through these demonstration projects, we'll be able to grow the chronic care program and also include it as a model of care that will better help those of you who become family caregivers because chronic care is not managed the way it needs to be. And I'm going to, on the discussion of the legislation on this bill, I'm going to close with a couple of issues to keep on your radar screen for the future. One being hospice care. It wasn't addressed in this bill, and in part because the Republican leadership really shoved this legislation down our throats very quickly. They were on a rampage to get this bill considered by the 4th of July. And when you're talking about adding a prescription drug benefit for 40 million beneficiaries and how to carve up $400 billion on the table, a lot gets consumed on how to spend that money, and the discussion on how to reform the programs is often left to the side. And one of the things that got left behind was how can we reform this treasured benefit that we have in our country but is so underutilized, which is known as hospice care. And why is it that we have right now pretty much limited access to the benefit by saying that you only can qualify if you only have 6 months left to live? There's a lot we can do to build on, improve, expand this benefit. It's worked wonders. How many in this room have even had the opportunity to be involved with hospice care? And by round of applause, how many of you would say that it was a positive experience? That's one of the messages that we've got to get better at taking, not only to our friends and neighbors in the community who are probably unaware that the benefit even exists or how beneficial it has been to you in your own caregiving role to receive this benefit, but what more can be done to expand it so more families can raise their hands and clap at the next conference. One other idea that we're kicking around internally in Senator Kerry's office is promoting one of the things that the states say they can't be in compliance with that Olmstead decision like I talked about, and when they whine and complain and say that they cannot bring more home and community-based services to people is it's resource intensive. It costs money. We don't have money. We're in a state fiscal crisis. Well, I think we're standing at a crossroads of an interesting opportunity to promote a way in which we can swap out responsibilities from the federal and state level and put some requirements on the states to actually do this. And that is in the Medicare prescription drug bill. There's a fight right now over whether or not seniors who are called dually eligible, low-income seniors that qualify for both Medicare and Medicaid coverage right now, get some prescription drug benefits under Medicaid. And so as we bring on a prescription drug benefit for all seniors, there's a question of, do we keep those low-income seniors to where they still get their Medicaid prescription drugs or bring them into the program? If we bring them into the program, as many Democrats are advocating, because if you leave seniors to the whims of state-by-state prescription drug programs, they're going to have a lesser benefit than the seniors under Medicare who have the standard benefit across the board. Let's bring all seniors. Everyone pays into Medicare the same. They should be able to benefit the same. Let's bring them all in. But by doing that, you've got to think we are creating a vast amount of wealth that we are going to be transferring back to the states by taking that burden off of them. Because the way the Medicaid program works is it's both federal and state share. The states pick up at least half of the cost of the Medicaid program in most instances. So if we are removing a large number of seniors who currently get the prescription drugs off of the Medicaid program and putting them into the new Medicare benefit, the states are going to save multiple billions of dollars a year in prescription drug expenses. That's part of what the fight over right now. It's a dollars fight in Washington. Are we going to take this burden off the states? Some of the Republicans are seeing it as a resource fiscal fight. A lot of the Democrats are seeing it as a consumer issue. Let's do what's right for the seniors. And what I'd like to see us interject in here is if we're going to give states that fiscal relief, it better be with some sort of string attached. And why don't we have that string attachment be that if we're going to give you the fiscal relief for seniors on prescription drugs, we require that you spend the same amount of resources that you're going to save from this invested in home and community-based services for elderly and non-elderly people who need care. It's a requirement under the law that you do it. The Supreme Court says that you must. You complain that you can't be in compliance because you don't have the resources. We are handing them to you, but don't you dare plan to use this money on roads and bridges. Why is caregiving not a priority? Well, advocates for volunteers are always less powerful in Washington, D.C. than the moneyed special interests that have lobbyists. The hospitals, the physicians, nursing home, pharmaceutical companies all have representatives in Congress that are on the doors, knocking on the hallways, taking you out for those nice golf games and those fancy lunches. Maybe hell's a little like Washington, D.C. It's hard, but you have a story to tell, and that's what's more powerful, and I'll get to that in a moment. I'm going to wrap up this with saying high-tech bias in American medicine is something that you're also up against. Procedures and pills trump tender-loving care almost every day. When you go and you talk about whether or not to invest in new forms of medical technology and procedures and new pharmaceutical, explorations, that sometimes captures the mind and imagination of policymakers much more so than supporting people who are out there giving tender, loving care. The strategies to gain support, and that's what I'm going to close with. We need to gain support in this cause, and in part, time's on our side, so in some ways it's going to happen naturally. With the aging of baby boomers and with more and more people becoming caregivers or needing care themselves, we're going to come to a point of critical masses where we're most definitely going to have more and more people advocating for respect of the family caregiver. But we need to be sure to tell our story. Ed Markey's an advocate in Congress in large part because it's something that happened to him personally. But I can guarantee you that many members of Congress would be just as passionate if they had to spend time to sit and hear what your story is. I don't know anyone who, once they're told sort of the heart-wrenching details of what it takes day in and day out to be a caregiver, that doesn't become a champion. It's just those out there who don't know what you do. So be an advocate. Shout from the rooftops. And in part, I think one of the reasons why respite care doesn't get passed is because, boy, if we give these folks some respite care time and allow them to leave the house, you're going to all descend on Washington, D.C. and tell us what it is we need to do. But let's work in coordination with that. Let's use some of the respite care time that we have to be agitators, to be agents for change, to be advocates, to tell our story and to move people to understand that this is something they no longer can ignore. We must also raise the ability by promoting the cost-effectiveness argument that exists here. If we were to replace all of the family caregiver hours in this country with paid workers, it would cost more than $200 billion each year. Tell that to the bean counters. Have them understand that the cost of not doing something, if we all threw up our hands tomorrow and said, you know what, I can't take it, I just can't do it anymore, we would have a crisis of national proportion on our hands. It's a cost-benefit analysis that I think a lot of folks don't stop to think about, and once they do, become very well versed and educated in the fact that this is something they no longer can ignore. Given that we're short on time, I'm going to wrap up there, and I'm going to encourage all of you to stay in touch with our office as well. My contact information is on the last slide. My hat's off to you for all the wonderful work you do, and we very much appreciate being your partner in this advocacy for change.
Thank you very, very much. I know that they're very excited about this awareness building in Washington, D.C., and maybe a march of family caregivers. So I share that with all of you. Next, we're going to hear from Joanne Prince. Joanne Prince is the winner of the 2002 National Family Caregivers Association Caregivers Voice Award. Joanne is a graduate of Lemuel Shattuck Hospital School of Practical Nursing and has been in nursing for 38 years, the last 20 in geriatric nursing. She was a caregiver for her husband, who died in 1981 after 5 years of illness. Her retirement, in quotes, meant she could devote herself full-time to being a senior activist with a focus on racial and ethnic health care issues, through the National Caucus and Center on Black Aged, the Older Women's League, and as co-founder of the Multicultural Coalition on Aging. Joanne Prince.
Good morning. It is indeed a pleasure to be here with all of you caregivers. I'll tell you, I had no idea what it was to be a family caregiver until I had my own experience. As nurses, we would take care of our patients, go home at the end of the shift. Yes, sometimes we carried our concerns for our patients home with us, but we knew we were coming home to our own loving, healthy families. In the early 70s, my husband was diagnosed with prostate cancer. In the beginning, we were all hopeful that he would be a survivor, but that was not to be. The last year of his illness was a revelation for me. He decided to make a choice to forego any further treatment. He had fought the good fight, but the cancer was just taking over his body. I had to step in and be his advocate to deal with the issues of end-of-life care. Back in the early 80s, there was not hospice care. And if I did not have a nursing background, I'm not quite sure if I would be standing here today. It was in a very emotional time. I had to put the end-of-life care in place. The nurses were wonderful. I had to talk to the doctor about, he's dying. Let him die with a sense of dignity and compassion, not retching with pain. We had to learn how to manage the pain. Then I began to think of other caregivers who are going to go through a similar experience. I thought of some of the caregivers I sat with in the hospital when I would take my husband for his treatments, and they shared with me what they were going through. It is so hard, so difficult. And only those of us who have been caregivers really know what that means. So I moved on after my husband died. I was in a great state of depression. I was so drained, I had no idea what I was going to do with my life. But somehow or other, there was no counseling now, but it was my faith. I think if I did not have a strong faith belief, I would not have been able to pull myself together. My doctor did give me some antidepressant medication, but I'm not much of a medication taker. I took two of those pills, and I said, I just can't do that. I have to trust in my inner spirit and find out how I'm going to move on with my life, and it was through my own faith belief. I returned to work, and I must say the last year of my nursing has been in geriatric practice. 6 years in the community, and the last 14 years of evening charge nurse in a long-term care facility. I would like to just share some of the comments I heard, especially in the community, from some caregivers. 1, my husband and I have been taking care of our retarded adult son since he was born. We are growing old, and my health is failing. I think we know what that's all about. Number 2, I have been helping my mother care for her mother. Now my mother is so worn down from it, and I have to work and have my own family, and I just don't know what to do about that. That's the sandwich generation, and could very well be what they call the club sandwich generation, which means you might be caring for 2 or 3 more. The other was, my sister refuses to have anyone come into her apartment to help her. She only wants me, and she can be so demanding. I am just at my wit's end. So we know a lot of caregivers who are caring for family members like that. They don't want to, they do refuse help to come in. They just want their family members to take care of them. Now, we need the support. So for caregiving, for some has been for many, many years, and for some it's just been short term. Since the 80s, I have been involved with support for caregivers, mainly through an organization called OWL, now known as the Voice of Midlife and Older Women. In 1989, National OWL published a report, Failing America's Caregivers. the seed was planted. Here it is, 2003, a national caregivers movement with emphasis being placed on community-based care. That's where we really want to receive our care, is in the home as long as we possibly can. And how can we prepare? What strategies can we use to make this possible? I think one of the things that we can do is to reach out into our faith communities. There is a wonderful gathering, and many people within the faith communities are saying, what can we do? Our congregation's growing older. Some who used to attend church or faith services are not able to do so anymore. Let's find out who the caregivers are. Let's begin to educate our baby boomers. First wave of baby boomers now will be 58 years old next year. That means aging, they're going to grow older, they're going to have parents who live much longer, they're going to be caring possibly for great-grandparents. I think Dr. Pearls, who has done a lot of research in living longer, talks about people living to be the age of 100. So that's really quite something. So I think education is the key. I would like to see our baby boomers to take time and know how the elder care system works. During my years of nursing, many times adult children stood in front of me. Their parent or loved one could no longer make decisions, and we had to ask them, what choices do you want to make? These are your options. They would just look, I don't know. And sometimes I would ask the question, have you ever had this conversation with your loved one? No. Many of them did not even know who the primary care doctor of the loved one. They did not know all the pertinent information. Was there a will in place? Power of attorney? All those kinds of things. So it's a new day as we begin to age in the 21st century. I have sat down with my two daughters and had that caring conversation. I'm sure they felt a little uncomfortable at first, but I said to them, it's a gift I'm going to do and give to you, to have my own affairs in order, and each day that I have, I'm very grateful to have it. As the book of Psalms says, we have 70. I have reached 70 and then some. So I feel that what time I have left, I will strongly always advocate for you family caregivers. You are the backbone of the health system. Thank you.
Thank you very much, Joanne. All right, moving on. Next, Sue Miller. She's the author of 6 novels: The Good Mother, Family Pictures, For Love, The Distinguished Guest, While I Was Gone, and The World Below. Also a collection of short stories, Inventing the Abbotts, and a memoir about her father's illness and death from Alzheimer's disease, The Story of My Father. She has published articles and reviews in numerous magazines and journals. 2 films and a television miniseries have been made from her works. She has won a Guggenheim Fellowship, an Atlantic Monthly First, a McDowell Colony Fellowship, and was nominated for a National Book Critics Circle Award. Quite a treat for us to have Sue Miller with us today. Sue Miller.
I'm here because of the book that I wrote about my father. My father was a church historian, which made his illness with Alzheimer's disease something of an irony, in fact. But he was an odd person in some ways in that he had never much been concerned with his own personal history. He was also an ordained minister, though he never had a church. He was primarily an academic. And I was his caregiver for the last 3 years of his life. He was diagnosed in 1986, though we'd noticed, and he had known, that something was wrong long before then. He would report things like driving along the highway and suddenly being aware that he had no idea of where he was or of where he was supposed to be going. You know, it was as though he said he had been plunked down from another planet and was at the wheel of the car. He also continued to teach until too late and reported to me once launching himself into, you know, a sentence many times over, actually, and finding himself in the middle of it and not being able to remember what the thought was that had started the sentence, and having to do an enormous amount of kind of intellectual fancy dancing to get himself to an end of the sentence that made, he hoped, some sort of sense to his students, which it decreasingly did. His last year of teaching, he got just terrible student recommendations, and I think that's part of what persuaded him he had to stop. His care, from my perspective, as a caregiver, was easy. He had wished always not to be a bother to us and had made plans. My mother had died long before he did, and he had made plans to go to a sort of a church retirement community. It turned out he couldn't go there once he was diagnosed. But it was that impulse to sort of not be a bother that had made him think of this in the first place. He couldn't go there because they didn't have continuing care, but it was his wish, once he was diagnosed, to be institutionalized, essentially. But he asked to come and be near me. So it was my job to help him find a place to be, which I did. And then I was really the one in charge of him. My family is like a lot of American families, scattered all over the United States, and there was no way that we could share this. I have 3 siblings. It was going to be one person's job, and it ended up being my job. Made much easier because his sort of daily needs were taken care of. But I felt very strongly the responsibility for his emotional state. I was his sort of linchpin emotionally. There wasn't very good Alzheimer's care at this point. He was mixed in with the general population. And I felt that the nursing staff, which wasn't specifically trained to take care of Alzheimer's patients, wasn't particularly skilled at dealing with him. So I felt very much as though I was the one person who could speak to him, who could understand what he was saying, who understood who he was and who he had been. And so it felt very important to me to be with him a lot, and I was in the last years of his life. And I just want to read a few short passages from the book that I wrote about that experience of dealing with his Alzheimer's disease, and the feelings that it engendered in me as a caregiver, even though it was easy. He was an ideal patient in some ways, and he wished everything to cooperate, and did cooperate until he became so demented that he really didn't know what cooperation was anymore. This is just a sort of a comment on my sort of sense, despairingly, as he got more and more ill, that I wasn't sure it mattered whether I saw him or not anymore. What I saw, right or wrong, what I despairingly concluded, was that my presence didn't matter. While perhaps sometimes it was comforting to Dad, it didn't and couldn't ever change anything. This was a lesson I had to learn over and over with my father's illness, even up to the end, that it would be progressive no matter what I did, that he would get worse no matter what I did. I think this is the hardest lesson about Alzheimer's disease for a caregiver. You can never do enough to make a difference in the course of the disease. Hard because what we feel anyway is that we have never done enough. We blame ourselves. We always find ourselves deficient in devotion. Did you visit once a week? You might have visited twice. Oh, you visited daily. But perhaps you would have done better if you'd kept him at home. In the end, all those judgments, those self-judgments, are pointless. The disease is inexorable, cruel. It scoffs at everything. Still we look to ourselves to have made a difference. We remember everything we didn't do. I think in part what Alzheimer's leaves you with, what caring for someone with Alzheimer's leaves you with, is a great wish for mastery over something, because you feel a failure in so many ways, necessarily, I think. It seems to me that Congressman Markey's involvement in politics, in the politics of Alzheimer's care at this point, is a wish for mastery over this experience. As my writing this book, which took me a very long time to write, was a wish for some sort of mastery over the experience too. And I think part of it is that you feel debilitated yourself, even as a caregiver, by the disease. I'm going to read one more passage and then I'll sit down. But this is really about, I think, through a small example, dramatic example, what caregiving does to you. One day when I came in, my father was agitated. After I'd sat down, he said with some pressure in his voice that he needed to tell Sue something. I said I was Sue. He looked panicked. Well, yes, I know, he said, but I mean the other Sue. I need to get in touch with her. Another Sue or Sue Miller? No, Sue Miller. I need to tell her something. We went round the confused circle at least once more before I gave up trying to persuade him I was the very person he was thinking of, and suggested he dictate to me whatever he needed to tell Sue, and I would see that she got the message. He began with long pauses between nearly every word. Dear Sue, he said, I am writing to the one we know as Sue, to be in touch. I waited. So that Sue can hear what I need to tell her, which is, I asked after a long moment, that I need to be in touch with Sue. And so it went, only the need being announced, never the message, though we sat for 15 minutes or so, and I carefully wrote down each fumbling word. It seemed to me, thinking about it afterward, that what had happened was that his memory of me and the person he saw and recognized as me when I visited him had somehow sheared off from each other. And of course it's true that any person you know well has multiple ways of existing in your mind. The Sues in his brain, I thought, were not all one Sue. Oddly, sadly, I also felt he was getting at something else, a deeper reality in his confusion. For in my treatment of him, I had become another Sue, a caretaker Sue, a cheerful, dismissive Sue, a Sue who, from his perspective, was grossly insensitive to the shocking and astonishing and sometimes painful things he reported that went on daily in his universe. He was delusional. A Sue who had taken his car away from him, who was inattentive when he said he had to have new glasses, when he told her his books were missing, gone, probably stolen. If he was altered, I thought, so was I, and strangely, in some of the very same ways he was, made bland and callous, reduced by Alzheimer's disease. Thank you.
Thank you very much. This whole field has given rise to a lot of wonderful writing, and the most recent book I have read is indeed Sue Miller's own book, and I do recommend it, and there's quite a bit of literature emerging right here, I'm sure, from this audience. The next person I want to introduce is Susan Leahy. Susan is Director of Media Relations for Blue Cross Blue Shield of Massachusetts. Susan coordinates the company's responses to media inquiries. She also leads the company's efforts to promote Blue Cross Blue Shield of Massachusetts' position as the leader in the Massachusetts health plan marketplace. Susan is a key contributor to the company's communication strategy and provides valuable counsel to the company's public policy initiatives. Welcome, Susan.
Good morning, and thank you for the opportunity to address so many valuable people in the healthcare system, so many heroes, as we've heard many times this morning. I'm here to talk about what companies, what employers can do to provide some flexibility in your lives. Many of you probably know a lot of these things. Many of you, I hope, will hear some good news that you can take back to your employer and ask them to adopt these policies, not only to benefit your lives, but the lives of other coworkers. First of all, companies can provide flexibility for their workforce. And there's a cost-benefit analysis for the company. It takes so much money to recruit, to hire, and to train employees that if you develop increasing home responsibilities and you have to be elsewhere, it's in the company's best interest to provide you with that flexibility rather than to see you go and have to hire and start all over again with somebody else. So ask your employer if they can develop some flexibility. And here's an example of how it worked at my company. Because many people work during the day and don't have time to call the Blue Cross and Blue Shield call center between the hours of 8:30 and 4:30, we expanded our hours to 8 p.m. That fit in nicely with employees who had caregiver responsibilities in the middle of the day. So there now are employees who work 8-hour days, but over a 10-hour period. So they have a chunk of 2 hours in the middle of the day to run errands, to go to the pharmacy, to go home and check on a loved one. And for Blue Cross and Blue Shield, we have somebody who we trained, somebody who is loyal to the company, and somebody who can work until 8 o'clock at night answering your phone calls. Flexibility has another benefit for the company. The more companies that provide flexible work schedules, the higher regard they are in their community. And Working Mother magazine and other national and local recognitions are things that companies like mine strive to do because it's a competitive workforce, a competitive marketplace for talent out there. We're competing with Raytheon, with Fidelity, with State Street Bank for the skill sets that we need to operate our company effectively. So we can look as flexible as possible to new workers. We'll be able to attract and retain a talented workforce. Also, the Gen Xers and the Y generation, they grew up watching their parents, sometimes both parents, work full-time and saw the struggles that they put up with. They don't want to live the lives, the working lives that their parents did. So they're attracted to companies that offer flexible work schedules, work at home, telecommuting, and so it behooves a large employer who is looking for talented Gen Xers and Generation Y employees to be as flexible as possible. Companies can also offer access to resource referrals. There are agencies out there, and many of them are represented here today, that provide companies with assessment of caregiving skills, nursing home placement information, insurance information, and other legal and financial consultations. They do the work for you. So ask your employer if they will negotiate a contract with a referral service. And again, for the company, it means that their employee is not doing this on company time. So it's really in their best interest to hire a referral service that will do the work for you. Many companies also have an employee assistance program. You can call that service, and they will put you in touch with an elder care specialist. I took advantage of this recently when my father was diagnosed with colon cancer, and my mother was left at home, not with caregiving responsibilities, but with a shattered existence. So I tapped into that resource to speak to an elder care specialist who could advise me how to work with her about moving away from the life she had led to the independent life that she was going to be leading soon. And they were a wonderful resource. In addition to flexible working schedules, many employees take advantage of the Family Medical Leave Act that Heather spoke about recently. And at Blue Cross and Blue Shield, we don't have as many people as we'd like to take advantage of it. 15% of our female workforce has taken advantage of the Family Medical Leave Act, and only 1.5% of the male working at Blue Cross have taken advantage of it. I think that will grow with time, and listening to the speakers today, I've heard some ideas that I think I can bring back to try to encourage and support employees who want to take advantage of the benefits under the Family Medical Leave Act. So in closing, I urge you to talk to your employer, talk to your partner's employer, to see what kind of benefits you could put together from both organizations, and remind them that it really is in their best interest to work with you. You're a valuable employee. They spent a lot of money training you, and the more flexible they can be, the more attractive they'll be as an employer of choice these days when there's such high competition for talent. Thank you very much.
Okay, thanks. All right, our final speaker is Alan Solomont. He is chairman and CEO of Solomont Bayless Ventures and co-founder of Houseworks. Before creating Solomont Bayless Ventures in 1998, Mr. Solomont was chairman and CEO of the ADS Group. Guided by Mr. Solomont and his business partner, Susan Bayless, ADS became New England's premier network of elder care services, including more than 50 nursing care facilities, assisted living residences, senior housing developments, and home care ventures. He also serves as a director of the Boston Private Bank and Trust Company and as a managing member of Angel Healthcare Investors, LLC. Throughout his career, Mr. Solomont has supported numerous community institutions and charitable organizations. A leader in the Democratic Party, Mr. Solomont is currently the co-chair and member of the Board of Boston 2004. That is the host committee for the Democratic National Convention. Alan Solomont.
Thanks, Madge, and thank you for doing this. The Bible says that the last shall be first and the first shall be last. And I not uncommonly seem to be the last speaker on a program. And when that happens, I like to talk to people about fear and hope. You're afraid that this program won't end, and you're hoping that I will be brief. I'll do my best. I know this isn't a political gathering, but there have been a couple of political statements mentioned, and I just wanted to tell you that one of the reasons why we should send John Kerry to the White House is he will take Heather Mazur with him. This is a very interesting group of folks, and I'm very pleased to be part of it. I'm going to talk a little bit about elder care, both a historical perspective and a current perspective, and where I think it's going. I have been in the field of elder care now for 20 years, and if you count my years as an orderly at the Duville Manor Nursing Home and my training as a registered nurse, I guess it's 3 decades. I often said as a business person I was much more comfortable in a room full of white hair than I was in a room full of white shirts, and now the people with white hair are my peers. When I began in elder care in the late 70s, things were much simpler than they are today, at least they seem to be. Seniors who needed care received it either at home, in a hospital, or in a nursing home. Medicare paid for the hospital, Medicaid or private resources paid for the nursing home, and most care at home was provided by family and friends, the way it is today, for free. Nursing homes were actually a relatively new phenomenon, or young institutions. The modern nursing home really dates back to the enactment of Medicare and Medicaid legislation in the mid-60s. And in the mid-1980s, half of the residents of Massachusetts nursing homes had no living relative closer than a niece or a nephew. I was always puzzled by the disproportionate number of school teachers that I met in nursing homes, until I was told that even in Massachusetts, in the earlier part of the 20th century, it was illegal or prohibited for married women mostly, to teach school. So that in fact, one of the missions of nursing facilities in those days was to take care of people who had no families. I was frequently asked to advise families who were struggling to take care of their mother or father at home, when should we think about a nursing facility? And I used to say to them that when you become a nurse and not a daughter or son, when you are no longer Sue, and you can't actually be a son and daughter and both enjoy and experience that emotional connection and the support that a son or daughter or niece or nephew provides, then you might at least consider a professional institution to do that, and that will free you. So that was seen to be, in those days at least, a relatively good way to frame the choices. People weren't very interested in what we called then long-term care. Now I like to call it elder care. Some people used to be in the banking industry, now they're in the financial services business. I went from the nursing home business to the elder care business. But people just weren't interested in it. First of all, as people have mentioned, medicine and the entire healthcare system in the United States was really on a mission to cure disease and prevent death. In those days, we didn't use the diagnosis of Alzheimer's. Everyone who had some cognitive impairment carried the rather ugly diagnosis of senile dementia. There were no differentiations between Alzheimer's or vascular insults, etc. Also, the population that we cared for was really quite invisible, either because they had no family, and certainly because they had no voice themselves. And seniors, the powerful senior lobby in those days, was much more interested in issues that affected independent, healthy seniors, and weren't particularly interested in frail or disabled seniors. But things began to change, because in fact, death as the outcome of disease declined, and life expectancies went up. It accelerated Ed Markey told us earlier about how we gained 30 years in the last century, but even in the last decades it has accelerated. Seniors who survived acute illnesses presented with different kinds of problems of chronicity and disability. In fact, there's a very strong correlation between age and disability. 22% of people between the ages of 75 and 84 have some level of disability, and 42% of people over 85 have some level of disability, and it's really the connection between disability and the need for support and care that we're really talking about. In addition, long-term care became increasingly a need of mainstream middle-class families. It was okay to talk about Alzheimer's because it was happening to so many people. It was okay to talk about the struggles of taking care of an aging relative. People were living longer in an unprecedented fashion. And of course, families themselves were changing as they became more mobile, and more families had two spouses working. And so we saw the emergence of the sandwich generation. And for the first time in all of history, middle-aged couples had more parents than children. As the population changed, elder care or long-term care changed. There was a proliferation of new sites and new models for caring for people: congregate housing, retirement communities, adult day health, assisted living, increases in home care, and better and more sophisticated nursing homes. These things all happened really over the course of the 70s, 80s, and 90s. And this country began spending serious money on long-term care. In 1998, we spent $117 billion in public, $117 billion in total on long-term care. 30% of it was out of pocket, $35 billion. Medicaid was the largest payer, 40% of this. Medicare was a distant, actually a third, paying for 18%. But at that time, 98, and it's considerably more now, the government was contributing about $82 billion to long-term care. And I want you to remember that number. It'll come up again. But mostly the money was being spent on residential and institutional solutions. Only $30 billion of the 117 was being spent on home care. But describing public expenditure certainly didn't tell the story then any more than it tells the story now. And in fact, today, 86% of all disabled adults over 50 rely on family and friends for assistance, and 61% of them rely exclusively on family and friends, on all of you. Over the years, or more recently, I guess, I got religion. And I just want to say a word about how that happened, because as Madge mentioned, for 20 years I was involved in a company called the ADS Group, and we focused on building a network of elder care services that included nursing homes and subacute care and assisted living and senior housing and some home care. But for the most part, we were focused on bringing seniors to our facilities for services. But after leaving the company of 1997, we wanted to create a new model for elder care. And so we created a company called Houseworks, which brings services to seniors where they are. In fact, Houseworks is dedicated to helping seniors stay independent in their own homes, to bringing services to them, and to help families by complementing and supplementing and sometimes replacing for short periods of time their own care. We sometimes describe ourselves as a son or a daughter for rent. We offer a menu of services that include home repair, home adaptation, handyman or handywoman, escorted transportation, and in-home assistance, companions, caregivers, either hourly or live-in. It's not health care. We don't pretend to be health care, and because of the rules, it's neither is it third-party reimbursable. But this year alone, out of our offices in Newton that serve the greater Boston area and Danvers serving the North Shore, we will take care of over 3,000 people. In fact, some of our folks are here today, and Andrea Cohen, who is the CEO of the company, had so much to do with preparing this morning's program, is in the back along with several of her colleagues. One of the things that we have found that caregivers are really looking for, and you probably know this far better than I do, is a solution to a problem. Not lots of information, not lots of education, but solutions to problems that are very immediate and very pressing. We've also been rather astounded by the lack of information that all of us as caregivers have and that we have been able to learn because it's not generally available. We pursued this strategy because everybody does want to be at home. And families are stretched beyond their capacity. And residential solutions, though they can work for some, don't work for everyone. And if we look to the future, there are 77 million of us baby boomers who are going to retire in the next 30 years. And the people over 85 will double between 1990 and 2010, which is only 7 years away from about 3.5 million people to 6.5 million people. And there are clearly limits in the public sector and even in the voluntary sector in terms of capacity or will or priorities. I've come to believe that at the end of the day, elder care is and will be always a family responsibility. The first time that long-term care ever rose on the national agenda to warrant mention in a presidential State of the Union address, which is a good measure of what is really at the top of a nation's agenda, was in a State of the Union speech that President Clinton gave in the mid-90s. I couldn't remember the exact year because none of us have memories that are as sharp as they used to. He announced or proposed a 4-point long-term care program. Now, this was the first time a president had ever talked about long-term care, certainly in a State of the Union address, although, frankly, in any context. And he proposed 4 initiatives. One, a modest amount of money for states to support family caregivers, tax incentives for the purchase of long-term care insurance, long-term care insurance as an option for federal employees, and about $100 million to Medicare to educate seniors and families to the fact that Medicare does not pay for long-term care. Essentially what the president was saying, and a Democrat no less, this is your responsibility. We will provide some tools to help you, but it's in your court. And in fact, you are the largest long-term care or elder care provider group in this country. And like any other provider group, you do need to organize and to make your voices heard and your needs known. And this town hall meeting and others like it are certainly an effective beginning. I think that in order to be effective, You need to understand the landscape, learn the business of Washington, set reasonable expectations, and form alliances. And if I may, I just want to share with you a few observations and suggestions from somebody who has labored in these vineyards for many years about what it will take what it will take to create long-term care and elder care services that are truly responsive to our current and future needs. There are three of them, and I'm closer to the end than the beginning. First of all, we have to completely overhaul the way we finance long-term care. The issues like institutional bias will not go away until we scrap the present system and build it anew. Because in fact, it wasn't designed to do the job it is expected to do today. And there is no funding program whose specific mandate and mission is to fund long-term care. The public entities on whose shoulders this burden has fallen really want to reduce their involvement. Twice the Medicare program got a little bit involved in long-term care at the very beginning of the program in the mid-60s, and then for a short window in the mid-90s. And it was too expensive, costs rose too quickly, and they turned the spigot off. Medicaid is the largest source of funding of long-term care. That's a program that was originally designed to provide health care for poor people, not to fund services that are directed to the middle class or to the general population. It is a federal-state partnership between two partners that are both reluctantly committed to it. It is the single largest line item in state budgets, and it is the fastest growing line item in state budgets, and it is probably the least popular line item in state budgets. Have you ever heard a governor say, "I want to be the long-term care governor"? It has a weak political constituency, unfortunately, because it basically serves people who are generally less enfranchised than others. And so it gets blamed for budget deficits, and then cuts are made in the resources allocated. And what's the outcome? There's certainly no expansion, and the services that it funds suffer in terms of quality because of the reductions. Most money is spent on institutional care. That doesn't mean that we spend enough money on institutional care. There are about 1.5 or 1.7 million frail elders in nursing homes in America. They have profound needs. They are not there because they want to be there. They may be there because they don't have other choices, but they are significantly disabled and dependent on others for care. And they are grossly, tragically, shockingly underpaid. We spend about, on average, $120, $130 a day to care for a frail senior, to provide room and board, nursing care, 24 hours a day, social services, activities, etc. You can't get a decent hotel room in Boston for $120 a day, and all you get are 2 chocolates on the pillow. You know, we expect, but I will say some things a little provocative, because we expect families who provide care at home to do it all with very little help. I think we expect families with members in nursing homes, frankly, to do too little. 80% of the residents of Massachusetts nursing homes are completely paid for by Medicaid. It's illegal for families to pay anything in addition. And if the public payment is inadequate, and it has been since the beginning, I would say, there's something amiss. So what we find ourselves doing is we provide families at home with very little support. We expect them to do it all, and we spend most of our money on institutional care, where we don't really seek to garner any additional resources. Unfortunately, this institutional bias gets providers fighting amongst themselves over really the same dollar, which leads me to my last point, which is that we really need to expand the pie, not to carve it up differently. That's really, at the end of the day, not going to meet the needs of our seniors or all of those who need care. And it is a political problem. Upstairs, in the lobby of the library, you will see not upstairs, outside. You will see to the left of the doors inscribed, this library is dedicated to John F. Kennedy and to all those who, through the art of politics, seek a new and better world. We've heard from 2 public sector employees today who seek a new and better world by understanding the world of politics, and we have to do that too. We're not going to make any inroads into this problem as long as we have a federal government and a state government whose major mission in life is to reduce taxes and therefore to cut existing services and to generate huge deficits. And we do have the resources. We are going to spend $87 billion on the initial reconstruction of Iraq. And we are spending about $82 billion annually in government funds on long-term care to take care of well over 2 million Americans, maybe much more. I know there are, and I will leave you with that uplifting thought. That is our challenge. We are all in this together, and thank you very much.
All right. I'm looking for Paul and Judy to sort of approach the microphones. They're going to be your inspiration to ask some questions of the panelists that you heard from today, as well as, again, our resource group who's sitting to the left. And I want to invite our resource group to feel free to jump in if you feel something in your area could be of some assistance to some of the issues that come up. And we're going to try and sprinkle in some of our questions from our online audience. Looks like we've got some from there as well. And once again, try and keep your questions brief so we can hear from as many of you as possible. Go ahead.
Good morning. My name is Paul Lynette. I am from Boxborough, Massachusetts, and have been pleased to participate in this multifaceted, collaborative effort of so many interested parties across the parameter of caregivers. For the past 6 years, I've been the principal caregiver for my wife. She is 45 years old, a disabled pediatrician who suffers from chronic progressive multiple sclerosis. So I paid close attention to Suzanne at the opening. My wife, her body is failing her, there's no question about it, but like many chronic diseases, multiple sclerosis takes an enormous financial and emotional toll on the entire family. When it became clear that my wife could no longer live in the home in which we were raising our children, we had the financial and emotional toll of moving to a new home. This was followed by the financial and emotional cost involved in finding and retrofitting a van in which we could transport her. And the one-time expenses were considerable, so were the emotional trials. But now we deal with the daily challenges of living with a progressive, debilitating disease and the escalating and constant out-of-pocket costs. Heather, I'm leading up to your point. Each month our family pays out-of-pocket more than $1,800 for 20 hours of a personal care assistant when we can find one, to bathe, dress, and tend to my wife. $560 for physical therapy, $75 for massage therapy, $250 in co-payments for medicines and supplies. The grand total on an annual basis is $33,000. $33,000 per year for the next several decades, we expect, and beyond, all this money is beyond the $10,000 we pay annually for medical insurance. My point is that the financial toll that is exacted if a loved one is struck with a chronic disabling illness as a young or middle-aged adult can truly devastate a family. Not many families can lose income, forego retirement earnings, and handle costs that we project might approximate $1 million. My question is, I know that Washington has been described as 20 square miles surrounded by reality, and that dropping the bill into the hopper is one thing, but what are the legitimate chances of enacting federal tax credit legislation to help families regardless of the cause of disability or the age of the chronically ill family member, so that we can really try to cope with these crippling costs. Thank you.
It has something to do with the tax credit. Yeah.
Unfortunately, folks in Washington often don't travel outside those 20 square miles to hit the reality zone. And since I am here in Massachusetts today and in that zone, I'll be quite frank and say in the near future, probably not a whole lot. Not a whole lot of chance, but, and I base that on the fact that we actually had a vote on this exact piece. Senator Mikulski offered an amendment when the last set of Bush tax cuts were on the table and the Democrats were fighting against it. We were throwing up amendment after amendment after amendment on ways that we were trying to say, no, this money would better be spent doing this. And we offered up, and Senator Kerry supported the Mikulski amendment to do the $5,000 tax credit for family caregivers. We're in an environment in Washington right now where, with the Republicans controlling both houses of Congress and the White House, that we can't do much without having in the Senate 60 votes, 3/5 of the body supporting what it is we're trying to do. So we're not even up against a majority at this point, folks. We got to find 60 people in the Senate that agree with us. And in that particular case, the amendment went down. If I recall right, it wasn't that we didn't have a majority, it was that we didn't have 3/5. And so while it's not a huge message of hope that I can give you in saying, yes, we're going to be able to get this bill passed this year, it is at least hope setting that we've got over half of the body supporting that we do this. We just need to work a little harder at getting to 60, or if I can be partisan for a moment, getting to a Democratic majority in the Congress and in the White House that understands the needs of family caregivers and is, in my opinion, a better steward of resources on where tax dollars should be spent and given back to families.
Thank you very much. Anybody else want to say anything on that matter of silent on the financial relief for the moment? Okay, Judy, did you have a question?
Yes, and perhaps Mrs. Bushnell or some of the panelists could answer my question. I too have a family member with multiple sclerosis. My husband and I are taking care of our daughter, who's 39 years old, have been caring for her for 3 years when she became no longer able to manage herself in her own apartment. The first adjustment, of course, was very difficult for her, becoming her parents' child again. So she's another, like Paul, of the young chronically ill. And so many of what you've addressed has to do with elder people. And I'll phrase my question after I give just a little bit more about our daughter Allison. She was a professional person who had to give up a job, her friends where she lived, to come and live with us. We're both healthy people, and we hope we stay that way. Often just transferring her from her bed to her wheelchair takes two of us to do it safely. When one of us becomes ill, we'll have big problems. We do have assistance from some public programs which she was on before she came to live with us, mainly in the form of PCA help, an attendant who comes in several hours a day. Still, we have long, involved evening hours, morning hours, getting her up and dressed and that sort of thing. So all of our well-being depends on our staying healthy. We can't consider a facility for her because there just aren't any available that provide the care that a younger person with progressive MS requires. The MS Society has been a wonderful resource for us and for her. However, we're wondering if there are some other things we don't know about yet out there that direct help and resources and outreach information toward people who are younger and have long-term illnesses.
Okay, thank you. Anyone want to go ahead with that? Okay.
I can address that.
Can you pull the mic a little bit closer to you? Thanks.
As many of you know, the Department of Public Health has had a relationship with the Multiple Sclerosis Society since about 2000, when the legislature, the Massachusetts legislature, had given money to the Department of Public Health to provide care, or actually what it said was go and, in my estimation, go and take care of MS in Massachusetts. It was a very broad legislative line, and the fortunate and unfortunate thing is that we were able to develop a care coordination program called MS Pass in 2000 and 2001. However, it was kind of caught in the 9C cuts a couple of times. However, this year, there is a small amount of the money that's been returned to the Department of Public Health, and we are in the process of getting that ready to reconfigure in a smaller way. We started out with $500,000 annually in 2000, and this year we have $162,000 and change. So we have to really think about how can we maximize those really tight resources. And at the Department of Public Health and the Division for Special Health Needs, we work very hard to make changes in policy to promote health among people with disabilities and chronic conditions so that they do stay healthy. And we try, with our MS Pass program, we have been able to refer people to the MS Society and to other agencies that do provide services. In your case, I think that it sounds like you have been connected with a PCA program through the Mass Rehab Commission. That's one of the sources that does provide some services. Unfortunately, again, it's a resource issue where there many times are waiting lists to be able to get into the supported living program of the Mass Rehab Commission. One of the lessons that we did learn with our MS Pass program, though, is that many people, particularly the younger families that have family members affected by a chronic condition, were unaware of Common Health, the buy-in public benefit program. And so that was an important lesson that we did learn. And it's not, it does help family members with disabilities who have some insurance or no insurance, provide some insurance coverage to be able to get programs that are out there. It's not the total answer to it, but it did help some families.
How do people find out about Common Health? Is there an 800 or?
There is an 800 number. You can call the Mass Health Customer Service Center, and please call me if this number is not correct. I got off the website, but I always leave that caveat, and I'll give you my number. But the 1-800 number is 1-800-841-2900, or TTY is 1-800-497-4648.
Okay. Question came, thank you very much. A question for Jean Brown that we've received. If you have an elderly relative in another state, which certainly applies to many people, oftentimes we meet, I do at a lot of events, I meet people with tremendous resources here in Massachusetts, and I say, so who's your counterpart in the New York City area, for example? Can you offer us some suggestions for kind of some of those quick ways to begin to get to crack kind of other regions if you live somewhere else?
Well, the best possible way is the Elder Care Locator. It's I brought a handout on it. It's in the on
And
the
it's
back
also in the
table.
back there. There is a brochure on that. Yeah.
There's an 800 number that any person, young or old, can call, and they will connect you with the local area agency or the state agency within any state within the country.
Okay, so start there. All right. There is a brochure on the table back there on Elder Care Locator. If you can just bear with me, I'm going to get somebody in from the internet because we want to be reminded that we have others who are tuning in that way and will only be with us for a few more minutes. Questioner asks, there is a need to support, recognize, and compensate appropriately certified nursing assistants and personal care attendants so family members have resources to access care providers. Do you think others, for example, such as paramedics, can be utilized to help the homebound? How do we foster and support ideas like this? Anyone want to take a crack at that in terms of other ways, both certification? Alan, you want to go ahead?
Actually, I wanted to mention a program that hasn't come up, but it's part of the Corporation for National and Community Service, which oversees AmeriCorps, Learn and Serve, but also the National Senior Corps. There's a program within the National Senior Corps called the Senior Companion Program, which provides opportunities for senior citizens to provide assistance to other senior citizens in their homes. There is a modest stipend that is paid to the volunteer and some additional modest costs to reimburse people for transportation. This program actually goes back to the anti-poverty program of the 1960s. It is being housed in the modernized national service movement, if you will. The Massachusetts Service Alliance, which administers the programs in Massachusetts for the corporation, is probably the best place to find out how to access senior companions. But it is a terrific resource. It is not as robust as we would like it to be, but when John Kerry is president, we'll grow it. Sorry.
Okay. Heather, go ahead. Yeah.
One other point. Is this on?
On there.
I think the marketplace will help create. We can address that issue by creating a bigger marketplace for personal care assistants, and once we get the MICASA bill passed, which I also feel very positive over a course of time. It's not going to be this year, it's not going to be next year, but we're building momentum and getting the right people to focus on this legislation in Washington. When that bill is passed and you actually have the ability in your home for the person who needs care to have the resources to pay for personal care assistance, you're going to create a larger marketplace for this, and that in and of itself, I think, will drive us to having more people go into the profession and have better standards for bringing the quality of that care up.
Okay, thank you very much. Joanne, go ahead.
I'm very supportive to our certified nursing assistants. They are definitely underpaid. They carry a very heavy load. Some of them have to care for 8 to 10 residents. And in our nursing homes now, our residents are very ill. It's a lot of heavy lifting, a lot of feeding, and most of our nursing assistants do not feel respected. So any of you who have loved ones in nursing homes, find out who their primary care nursing assistant is and thank them, recognize them. Can you imagine some walk into a home and come up and will ask the nurse, where's the maid? They're not maids. They're trained nursing assistants that do all the hands-on work that many of their own children wouldn't do for these particular residents. So let's push for more support for them and more reimbursement for them.
Okay. Step up. Is your question directed to anyone in particular?
No, it's not directed.
Okay.
Actually, I have two concerns.
Okay.
My name is Diane Smith, and my concerns are based on my experiences with my father, who has vascular dementia. My first concern is Well, we have low jack for cars. We have tracking devices for dogs, implants. We have GPS bracelets for children. Well, how come we don't have it for people with Alzheimer's and dementia? I'm asking because a month ago I had my father wandered and he was missing for 24 hours. And the horrors that ran through our mind were unbelievable. And we were very lucky he was found. We've tried to do everything possible, putting hooks at the top of the door, an alarm on the door, and everything like that. But you know, 24 hours a day. If you have caregivers in, if you go do your laundry, you never know when someone's going to wander. So for peace of mind, I don't understand why we haven't gone one step further. I know there's a program in Virginia called Project Lifesaver. They have radio transmitter devices. 16 states use this where they can find people if they wander. And I know we haven't, as far as I know, developed GPS bracelets for adults. So I guess my first concern and question has to do is when are we going to take the next step so that we can have peace of mind? Obviously, my father is much more valuable than a car and more important than a pet.
All right, let's take your first concern first so we can get someone. Anyone want to address that up here? And I'm curious if there's anyone from our resource table, anybody who might be able to say anything further about support for finding any wandering Alzheimer's patients. Yes, this person here might be able to speak to you further about that. Anyone here want to address this in terms of resources, interest at all? I'm not sure if it, go ahead, Alan. Yeah.
I guarantee you there'll be products like that in the next few years. This has been a silent problem. This has been a silent market, if you will, or issue for a long time. The fact of the matter is that historically most people spend more time, had spent more time looking for a new car than they had planning for what to do about if they needed to care for an aging relative. We've been in denial, but we are no longer. And actually there is a burgeoning industry of technological advances that will be available to deal with the problems that we're talking about. There are actually devices in residential facilities that protect people with Alzheimer's disease or with cognitive impairment from wandering, one of which is called WanderGuard. But I guarantee you that American enterprise has a very keen nose for new markets, and Heather mentioned before that a lot of healthcare is preoccupied with technology, but there's a lot of technology on the drawing boards or actually beginning to be out in the market that is going to enhance our ability to serve seniors. So I bet you if there's a conference like this in 2 or 3 years, there'll be lots of products like that, and there'll be sponsors.
Okay. I wonder if you can hold on for 1 second. In the interest of trying to make sure everybody gets in at least one question, if you can hold off for a moment on your concern. I think it's also time to sort of say goodbye to our online audience. You're going to stay over. Oh, okay. We're going to try and see if we can't get to all of your questions, those of you who are standing here. And this is a good time, though, to give you an email address. For any further questions that occur to you. He promises to get to all of them. That is our dear John Paul Morosi, and his email address is jpmorosi, and that is all put together, jpmarosy @charter.net. Okay, so that's something to keep handy if for some reason we can't get your question. Okay, go ahead.
My name is Arlene Lowney. I, too, have been a caregiver and a consumer. I've had 4 family members die with hospice in place, and my best friend a few years ago. None of them would ever have been in hospice if it wasn't for me, because it was not recommended. There were no referrals. The healthcare system sees that as giving up, the end, etc. And yet it made all the difference in their lives in terms of how they lived out the last months, weeks of their lives, and also for the family, the caregiver, the reason that we're here. Much of the work, and I also have been a hospice nurse and an administrator. I worked closely with John Paul when he was the director of the Cambridge VNA. I was the director of the hospice. So I've been on both sides of giving service and know that the care that you give to the families is every bit as important, and sometimes at the end we gave more support and care to the families as the patient was comfortable. And I guess I wanted to address my question to Heather, but also to say that I'm here today representing Mass Compassionate Care Coalition, a statewide coalition that is composed of individuals, organizations, and communities looking to improve care across the end of life. I think it's Hillary Rodham Clinton who said it takes a village to raise a child. Well, it takes a community at end of life. We cannot do this alone, and we can't leave the caregivers abandoned. So from that perspective, I guess going back to the hospice question that you raised in the beginning about broadening the benefit, I was there at the very beginning, the Medicare Demonstration Project. That was 83, 20 years ago. And the reality was at that time it was a different world in healthcare. We didn't have the technology, the ability we have now to keep people alive, often beyond a point when life has no meaning. Part of what I'm doing, like Joanne, talking about the gifts we give each other, we need to be talking to each other about what our wishes are as we age and as our needs change and we become eventually incapacitated. All the statistics say most of us will live long and well with chronic illness, but eventually we'll need help with decision making about how we're going to be cared for. We need to have those conversations, what we call advanced care planning, earlier, so that people will know we leave to chance some of the most important decisions about end-of-life care. Decisions are made in a vacuum because by the time people are in the later stages of Alzheimer's, they no longer can say what their wishes are. But that's an important conversation you can have when people are in the beginning and the middle stages. They will tell you, don't put a feeding tube in me. Don't jump on my chest. But if we don't have those conversations, Medicare, largest amount of dollars is spent in the last year of life. Question about hospice. I agree about expanding the benefit. It was meant for that defined time, mostly people with cancer. We're not including people with Alzheimer's. I now am the administrator of an assisted living facility, and we have an Alzheimer's unit with a palliative care approach. We begin that advanced care planning process when people move in. The question I have of you of the hospice benefit, not only expanding it in terms of not defined 6 months, could be a year, but is it possible to think about palliative care as an option where people can have consultations? Often if people are guided and have advocacy, they will make different decisions when they have to make them for their loved ones. They might not choose the ICU as the place to die.
Okay.
And certainly people can have the hospice services in the nursing home and the assisted living, wherever the home is. But that's my question.
Thank you very much. Okay,
Thank
Heather?
you.
Yeah.
Very quick answer to that is yes. I think that's on the table. Another important point that you made that was sort of implicit in what I was saying about expanding the benefit, but I think is a better way to bring it out, is changing the fact that families shouldn't have to, quote unquote, give up hope in order to access the benefit. Expanding it and modernizing it in a way that we can bring this continuum of resources that are helpful not only to the patient but the entire family, and having them access the benefit not because they've given up and said, okay, I'm going to die soon, but an acknowledgement that we can bring these services in at an earlier period of time to help a longer period of transition, and palliative care most definitely should be on the table with that.
Okay, thank you very much. Go ahead. Yes.
Hi, my name's Donna Culpa, and this is kind of like taking a risk for me today.
Welcome.
I'm a bumbling, stumbling member of Mass Families Organizing for Change, which I joined because I did not know what I was doing as a caretaker. But what I'd like to say is I've been very lucky to find a lot of professionals that have helped me, and I care for a child who is now a young adult with a developmental disability, but I am also a person with disabilities. And I have also helped my mother. I'm very grateful to hospice when she was dying. My child and I helped care for her. But I found, this is for the insurance agency, this summer, being someone who is dealing with mental illness, with epilepsy and diabetes myself, I was very lucky to have a tutor come into my cluttered house to help with my child as I fought for an educational placement. At the same time, I was taking pills, doing my blood pressure, dealing with the appeals process to see a psychiatrist, make a referral, fill out medical reimbursement forms to get money back from prescription drugs, which was very overwhelming to myself. I also know that there are many people with children and adults who would go to the cheaper HMOs if they would cover a larger range of areas and not just one specific area. So I wanted to let, since someone was here from the insurance agency, know that I hope you will realize that when you are having a breakdown or feel you might be, it's a little hard to pick up the phone and say, I need to see my psychiatrist in 5 minutes. Okay, thank you.
Thank you very much. Any comment at all, or point well taken? Okay, thank you. Here's what I wanted to ask our panelists. We're clearly running a bit over. Can you hang with us for another 5-10 minutes? Are people okay? If anybody does need to leave, we won't go much beyond that. If everyone again can try and sort of ask a question. I know everyone's got a lot of background to everything that's on their minds. But if we can get to that, then I think we'll get through all of our questions right now. I'm going to just interject a very quick one. It's another huge issue, but I just want to remind people of our online audience. Can we develop state registries of home care workers so we can report workers who might abuse the elderly or disabled individuals? I'm fairly confident there are some kinds of programs in state. Go ahead, Francis Lumima.
This is Larry Tumino, and I just wanted to share that we do have plans. We've been working with the Disabled Persons Protection Commission in this state to develop an abuser registry system. It's been quite difficult trying to figure out how to do that in terms of constitutional rights and information sharing. But we think it's necessary. We think it'd be really important to have something like that that will compare to the kind of query information that people already can't access when they're trying to hire people.
Okay, anybody else? Any other thoughts? Okay. Yes.
Hi, Dorothy May. I'm a teacher and have a husband with progressive MS for the last about 8 years. And watching the resources diminish very, very quickly. Can a caregiver, especially a teacher who doesn't pay into Social Security but has Social Security jobs up to the point where I have just 3 hours to get in order to qualify for Social Security myself, can you get any credit as a caregiver putting in hundreds and hundreds of hours towards your own Social Security to get those last 3 hours of credit? And the other one is if my daughter, who is willing at least for the next few months to come in and do some care, can I claim any of the money that I'm paying her?
I worked on the House of Representatives for 5 years before taking 5 years off to work for the Trade Association. And when I was there was much discussion about needing to do this. I must plead ignorance in that I've only been back on the Hill since April, and so I'd ask anyone else here who knows this. Let me put it this way, if it's not allowed, it's certainly something that you asking that question has sort of reminded me the importance of having that on the agenda, and I think it'll be something you'll hear Senator Kerry talking about in the near future.
Okay. And does anybody know the answer to the second one about if a family member, or maybe I should ask Carlos.
Well, we've got also Suzanne Mintz is waving from National Family Caregivers Association. Go ahead, Suzanne.
Okay.
The issue about Social Security benefits for family caregivers has certainly been talked about, but at this point, it's not in the cards, and I can't see it happening very, very quickly. In policy, you've got to go with the flow, and I think we would sooner see the tax credits passed than we will the Social Security benefits. But it's certainly not a new idea, and one that makes all sorts of sense, because obviously we are working and working very hard. Each state is so different in terms of payments, and especially when it comes to family members. Generally speaking, it's not allowed, but I would pursue it anyway. There's been some very interesting work done. There have been some Medicaid waivers on a program called Cash and Counseling in Arkansas, New Jersey, and Florida. And basically what the program has been is a way for people on Medicaid to have the option whether to go through the traditional system or to manage their own money. And in several of the states, they are allowed to pay family members. So, but you're also asking about whether you can deduct it as, medical expense, basically. And I would talk to my accountant about that. And I think, fine. I'll ask about that as well. And if you give your information to somebody, we can email some information back to you.
Thank you very much. We have time for one more question each from each side, and I do encourage everyone to take advantage of John Paul's email address. And once again, there are a lot of people with a lot of resources and information. Our panel here, there's other people who might wave their hands and say they've got, answers probably to some of the questions. Go ahead.
Them that's got shall have, them that's not shall lose. So the Bible says, and it still is lose. I'm Rosalie Cryan, and I was diagnosed in '89 with relapsing remitting, and I really couldn't tell you which is which today. But I really have to make a comment about the whole political atmosphere started by Ed Markey in the beginning, that besides taking away from the support for people and elderly and people who have earned it, our president is creating yet another generation of war wounded, and that includes all the soldiers and their families. I think it really is important to make multi-generational, multicultural, every facet of the human condition a part of one program for betterment. And I just have a suggestion for the PR person from Blue Cross that this probably isn't the best place to pitch their line. I know you need a job, so I know you also know that for every job for a highly qualified person that's available today, there are 500 applications of very qualified people. So that's, it's a good story, but it's not reality. Thank you.
Hi there. Thank you for letting me speak. I'm Leslie Corin-Ash, and I'm Director of Respite Services for the ALS Association of Massachusetts. I'm a medical social worker. I've been in home health care for many years, and so my questions aren't just about ALS, although I'm bringing up ALS because in the last year of life with ALS, you have a very high concentration of hands-on care 24 hours a day, monitoring the vent, monitoring breathing, monitoring secretions, and because there is constant risk of sudden death because of acute respiratory failure at any time, families are often up 24 hours a day, not for days at a time, for weeks and years. We have family caregivers who've only had 2 hours of sleep a night at most for years, and I don't know how they keep running. My concerns for these people are obviously they're totally physically exhausted. It's a good way to make a mistake when you're that tired and you're dealing with somebody where a simple mistake will kill them. Beyond that is the financial cost. You've heard from everybody here. Unfortunately, the answer to your question is no, you can't deduct that. No, the state doesn't pay family members. And Common Health is being cut back as we speak, so that although we used to use that, that program is severely curtailed. But there are other concerns. The family caregivers taken off 10, 20 years to care for their elder generation. They're not eligible for Medicare because they've been taking care of the people that Medicare didn't have to pay for because they were doing it, but they don't get any credit for that. I deal with family caregivers who are taking care of somebody who's on disability. They don't have a job. They don't have insurance. Their spouse has Medicare, so they can't take care of their own medical problems that come up from caregiving. They go on their credit card. They pay for their food and their rent on their credit card. The credit card companies don't give them a break. If their card says 15%, that's what they pay.
So do you have a question for,
What I'm doing is trying to address with Heather the ways that you can focus some legislative initiatives that look at the huge financial costs to caregivers, as I've just itemized, as a way to address that. And thank you.
Thank you very much. Okay, the financing comes up again and again. Thanks very much. Anybody? We didn't hear from probably just one or two people who might want to chime in. Go right ahead. Yeah.
Well, you haven't heard from me yet, and I'm in the developmental disabilities system in New Hampshire. And I guess I need to feel lucky that our system has recognized and has been able to get funding for families as caregivers. For about 10 years now, we've been able to fund individuals with disabilities as adults to remain at home and have a family member be paid for their caregiving. It is on a limited basis. Actually, only about, I think, 100 families in New Hampshire have chosen to be the paid family, instead of having someone else come into their home to provide the care. Most recently, we also got a Medicaid waiver for children in home support. It's a model waiver, and so for now, the limit is 200 families, and we have about 100 that are up and running. This is not for parents to be paid for children, although for adults, parents can be paid. But other family members can be paid. This is one of those family-directed programs, and so families can choose who they want for a provider, and they can choose, to some extent, the configuration of services that they want: personal care, respite, environmental mods, service coordination, or a consultant to help, perhaps, direct the personal care provider. A number of the families have children with autism, so they may want a behaviorist to come in a little bit and help develop the program. I guess I forgot to say that although parents can't be paid, grandparents, a few situations, a brother or sister, because we've also enabled the age level to be 15, 16, and 17 with parental consent. Usually a provider has to be 18 years or older. So I guess my point is that in some service systems, this has already happened. And so I guess it probably should and could happen in other service systems.
Okay, thank you for sharing that. All right, well, I want to thank all of you. Suzanne Mintz is going to come up with some closing remarks, and thank you all for your comments and your participation.
Oh, Lordy. I have been asked to kind of sum things up, and, where do I begin? There's just so much that has been said. But we've heard statistics and we've heard stories, and ultimately the two are so important. Policymakers listen to statistics. Statistics prove that there is an issue, but it is the stories that change direction. It is the groundswell of stories that get votes on issues that are important to us. So I really do need to encourage all of you to speak up and to share your stories. One way to do that is NFCA has a National Family Caregivers Story Project. It is a web-based initiative. The National MS Society is a partner, the U.S. Administration on Aging, the ALS Association. There are about 7 national organizations who are helping us with this. And you can go to our website, nfcacares.org, nfcacares.org, and click on the Story Project icon and just follow the directions. You might want to do your story first, just in Word or in paper or what have you, and keep a copy for yourself. But it is critical that you get it to us online, because that way it forms a database. And we can thereby use that database when we are on the Hill, when we are talking with the media, when we are trying to educate healthcare professionals who often really don't understand what family caregiving is all about. So I encourage you to share your stories. I am not sure we will see a caregiver march on Washington. It may just be too difficult for a lot of us to do, but we think the Story Project is the next best thing. And we've got about 500 stories now, but when you consider how many caregivers are, that's really just a drop in the bucket. So do it yourself and definitely spread the word. I would like to repeat some of the stats that we heard, because I think they get at the critical issues. We've heard over and over again about the financial cost of being a family caregiver, a caregiving family, especially for those of us who are caring for loved ones who are not seniors. When you think about parents of kids with special needs, you're talking about a lifetime commitment, and those kids are going to outlive their parents. When you talk about folks with MS, and that's my personal situation, MS is a disease of young adults. So, you're talking about decades and decades of care and lost income and all of that. The market value of caregiver services today is estimated to be conservatively $257 billion a year, and that doesn't cover all of us. That covers those of us who are providing care that is the equivalent of a half-time job or more. If you add on the folks who are doing somewhat less than that, you're going to add on additional billions of dollars. $257 billion, that is more than twice what is spent on nursing home care and paid home care services. We are literally underpinning the healthcare system in this country, and as somebody said, if we threw up our hands and said we can't do it anymore, everything would literally fall apart. We provide 80% of all the home care in this country, and as you heard over and over again, that is where people want to be cared for, in their homes. So those are some very important statistics. Other statistics, I think it was Heather who talked about the 11% of income. Caregiving families spend 2.5 times more on out-of-pocket medical expenses than families in which a person is not disabled, and it is just a little bit more than 11% of income. So literally, it doesn't look like a Mercedes and it doesn't drive like a Mercedes, but for us it is a fabulous machine, and not everybody can afford dollars like that. Most people can't afford costs like that, and yet transportation is such a huge issue for the disabled. If you saw me when I came in this morning, I was huffing and puffing. We walked here, me pushing Stevens in his manual wheelchair for when we travel, and I pushed him all the way from the hotel because the cab company just couldn't find one of the accessible drivers to show up, and that's happened the entire time that we've been here in Boston. But this is not just a Boston story. It happens in my own state of Maryland and everywhere else. And I could go on, but I won't. But the dollar issues have come up over and over again, and the talk of the initiatives about money following the person. Think about that a lot. Think about how you could live your lives if you were in control of the resources to get the help that you need rather than the help that some entities tell you would be the best thing for you at that point in time. For some families, at a certain point in time, it might be more valuable to go on a vacation than it would to get some additional physical therapy. We all have to decide for ourselves what's going to work at that moment. But in order for money to follow the person, that is going to affect the entire industry, because right now it is the providers who get the dollars, and changing it in through MACASA and in Medicaid is a way to start, but the majority of us are not on Medicaid, and so we have to look at this across the broader landscape. And so much of it comes back down to those 20 square miles in Washington and whatever the size of the state capitals are. We have to be advocates for ourselves and our loved ones, and we have to become activists for all caregiving families. That's what makes things happen. And I'm sure some of you are saying, how the heck do you expect me to do that? You know, I barely have time to breathe. But it really doesn't take terribly long to send an email or to make a phone call or to ask somebody else to do it. We have got to stand up for ourselves. We have got to tell our stories. I think it was Joanne who said that if you haven't walked in our shoes, you don't really understand, and it's true. And for those of you who have not had caregiving experiences, I hope you never will, but more likely than not, you will, because I can't imagine a family in America that's not going to go through this at one point in time, just because of the demographics. Linda had said to me a little while ago, there is so much focus on the elderly, and yet caregiving is indeed a lifespan issue. That's very true, and I think the reason that so much is heard about the elderly is because that's what the population numbers are. But we do need to recognize that it is indeed a lifespan issue, and more so than ever because of the wonders of medical science. There are more more kids with developmental disabilities today because they've been preemie births have been saved than any other reason. I mean, that's the downside of advanced medicine, and we need to put the two in sync. We've heard talk about choice, and we do have choices. And one of the choices we have is to recognize that we are family caregivers. Research has shown that by taking on the label, people become empowered. And when they become empowered, they speak up more and they reach out more for resources. They stand up more to the medical community and are willing to talk to their loved ones' doctors more. So there is power in recognizing that you are part of a group that is so large. Before I had said that there were over 50 million people providing care. Over half of us, more than 25 million people, are doing it the equivalent of a half-time job. So there are lots and lots of us out there. We are not alone and isolated, although I know so many family caregivers think they are the only ones thinking and feeling and doing what they are doing. We need to spread the word that we are a huge constituency that can have the power to make a difference if we make the choice to make a difference. And so that, I think, is my final message to you, and I think it is the message of everybody who has been here. Whether it is changes in the workplace, whether it is changes in the healthcare system, whether it is getting more resources, and definitely through policy change. I want to remind you about the National Town Hall meeting on February 24th on the Hill, and we are working with other advocates to put together a public policy agenda. If we can go together with force, with lots of organizations signing on, we will have some of the power we need. The town hall meeting on the Hill will be like this one in the morning, and then in the afternoon, caregivers will go to the Hill to meet with their representatives. A movement is starting. It's taken a while, but it is starting. But it can only succeed if we are all part of it, because it is ultimately our fight. And so I want to thank all of you for making the huge effort that I know it was for many of you to come here. I want to tell all of you the National Family Caregivers Association is here to be your voice as much as we can. Feel free to call our 800 number, 896-3650, or go online, and we will try to point you towards resources that can help you. And keep up the good fight.